Sorry about that. We currently have 6 registered public speakers for this meeting. Registered speakers are connected to the meeting by audio. The full list of speakers can be viewed online by visiting the board's webpage at toronto.ca/council and clicking the speakers box for today's meeting. I would like to remind all staff to keep their mics muted with their videos turned off unless they need to address the board. This will make it easier for me as chair and for those watching along on YouTube to observe directors as they participate. Directors, please keep your mics muted unless you wish to question staff or speak to an item, and please do ensure that your video is turned on whether you have children or pets in the background or not. As part of each agenda item, I will ask directors to raise their hands or unmute their mics if they wish to question staff or speak. I, of course, will create a speakers list. When voting on an item or a motion, and this is new from last meeting and it's a little easier, we'll ask directors to turn on their videos and I will ask you to raise your hands to indicate your vote. If there is a recorded vote, the board secretary will call out your names, but otherwise we are able to vote by video by raising your hands. Now, although we are in different locations and meeting remotely today, the Board of Health acknowledges the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Let me first start by asking if there are any declarations of interest under the Municipal Conflict of Interest Act. If you have an interest, could I ask that you unmute your mic and raise your hand to let me know? So a call for declarations of interest. I see lots of your beautiful faces, but no declarations of interest. Okay, carrying forward. May I have a motion to confirm the minutes from our last 2 meetings on January 13th and May 7th? I have a motion from Councillor Perks. All those in favor, please raise your hands. Any opposed? Seeing none, that carries. Councillor Layton just got into the frame. I didn't see his face, but a hand. I will count that. We will now proceed to review the order paper, and we do have a packed agenda today. The first item, HL 17.1, COVID-19 Response and Recovery. We have a staff presentation and speakers. The second item, so that's being held down. The second item, Toronto Overdose Action Plan, Status Report 2020. Again, we have a staff presentation as well as speakers, so I will hold that down. The third item, HL 17.3, 2020 Toronto Urban Health Fund Allocations and Review Process. There is a staff report with recommendations. Would anybody like to hold this item down? Hearing none, I will move the staff recommendations on that behalf. So all those in favor of the staff recommendations, please indicate by a raising of the hands. Okay, any opposed? Okay, that item is dealt with. Item HL 17.4, 2020 Student Nutrition Program Service Subsidies. Would anybody like to hold that item down? If so, I'd ask you to raise your hand and unmute. Okay, seeing none, could I ask Councillor Layton, you want to indicate you're moving that item? Thank you. So moving the staff recommendations, moved by Councillor Layton. All those in favor, please raise your hands. If so, any opposed? Seeing none, okay, that item is dealt with. Item HL 17.5, City Council approved Toronto Public Health 2020 operating budget. This is a staff report with a recommendation. Would anybody like to hold this item down? Okay, seeing none. Trustee Donaldson, would you like to move the staff recommendation there? I've seen the hand up, so all those in favor, moved by Trustee Donaldson. Any opposed? Seeing none, that carries. Okay, item HL 17.6, City Council approved Toronto Public Health 2020 to 2029 capital budget and plan. There is a staff recommendation there to receive this. Would anybody like to hold this item down? Okay, seeing none. Director Wong, would you be comfortable moving that? We're spreading the love around. Director Wong, Peter Wong, if you're comfortable, do you want to indicate? He is. Okay. All those in favor, please raise their hands. Any opposed? Seeing none, that carries. Okay. Item HL 17.7, Toronto Public Health Operating Budget Variance for the 12 months ended December 31st, 2019. I should give a note just before that this is the budget variance ending December 31st. As part of Dr. Davila's presentation, it will be going into the budget variance present to today, just so you're aware. But this is the variance ending December 31st. There is a staff recommendation to receive this item. Okay, moved by Councillor Perks. All those in favor? Opposed, if any? That carries. Item HL 17.8, Toronto Public Health Capital Budget Variance for the 12 months ended again December the 31st, 2019. Trustee Lopretti, would you mind moving that? Okay, moved by Trustee Lopretti. All those in favor? Opposed, if any? That carries. And then one last item is a new business item that I would like to introduce. It's being put on the screen. Item HL 17.9, Addressing Anti-Black Racism as a Public Health Crisis in the City of Toronto. We are putting this on the agenda, but I would like to hold it down. It will be posted and circulated, emailed around to all members and circulated. So I would like to add that item to the agenda, which I will move. All those in favor of adding this to the agenda? I could see an indication of hands. All those in favor? Great. Opposed, if any? Seeing none, that carries. Okay, so that has been that is on the agenda now, and it will be posted online and circulated. Okay, so now we will proceed then to the items which have been held. That is, so for everybody following along, because we're not in person, we have item HL 17.1, HL 17.2, and new business item, which is HL 17.9. Those are the three items in front of us. Our first item, which we now will return to, is 17.1, COVID-19 response and recovery. We do have two registered speakers on this. And so we have a comprehensive staff presentation. So we're going to begin with the staff presentation, followed by the speakers before we move it into committee. We'd like to proceed it that way in case there's information in the staff presentation that the speakers would like to reference or that we would like to ask the registered speakers about. So there is a rather comprehensive and fulsome update here. Dr. Davila, who is joining us remotely, can I turn it over to our fearless doctor to walk us through the presentation? Do we have Dr. Davila?
I am on the line. Can you hear me?
We can hear you fine.
Okay, perfect.
So Eileen,
thank you, Mr.
Over to you.
Thank you, Mr. Chair, and good morning, everybody. Colleagues over there at City Hall, I trust I will just let you know as the slides need to be changed. You'll let me know if there's any challenge with that. Thank you. And good morning again, everybody. As pointed out by the chair, I will be taking you through a comprehensive presentation to accompany the staff report on this issue. The report is an update on COVID-19 response and recovery, and the presentation is meant to supplement that. So let's move through the presentation. We'll start off, if we could move to the next slide. And the next one after that, we'll start with an update on COVID-19 budgetary impact. So to give members of the board a sense as to what we have heard thus far from the Ministry of Health in respect of expenses associated with COVID-19. The Ministry of Health issued a memo on the 23rd of April of this year, outlining a commitment that they have made to invest up to $100 million for the public health sector. The sector includes 34 public health units, local public health units around the province, Public Health Ontario, the provincial agency supporting public health science in particular, and the public health laboratories as well. and as well what is seen as part of the public health sector, according to the Ministry of Health, are the costs associated with running the assessment centers. It's interesting that this is incorporated into the public health sector, but it's important to note that the assessment centers are actually not run by public health, but are in fact run by hospitals in the system. But they are for the purposes of reimbursement or accounting for costs and the extraordinary expenses associated with COVID-19. They are incorporated here in this commitment for funding for the public health sector. We've been advised that there will be a process for public health units to be reimbursed for these extraordinary costs associated with COVID-19, and that reimbursement would be based on costs incurred over and above what can be managed within existing local public health units' budgets. We have all been asked to track COVID-19 associated costs separately, and we are anticipating that we will get further details on the specifics of the process for this reimbursement. But to assure the board that we are making sure that the province is continuously apprised of what is happening, we are issuing regular updates on spending and communicating those to the province so that they appreciate on a regular basis what sorts of costs are being incurred as a result of the COVID-19 response. Turning to the next slide, we'll now then look at the 2020 cost-shared budget for Toronto Public Health. The Ministry of Health has yet to confirm Toronto Public Health's 2020 budget. As you can see here on the slide, there's a figure of just under a little over, I should say, 191 million. This figure is the anticipated budget based on communications we've received from the province in 2019 regarding our 2020 budget. Just to be clear, though, the Ministry of Health budget excludes the Ontario Seniors Dental Care Program, but it does include in TPH's budget, as indicated on the slide, $35 million for communicable disease control activities. This funding is actually meant to support a number of communicable disease programs and services, things like TB, HIV education and prevention, outbreak management and support to a variety of different settings, inspection of personal services settings, some sexual health clinical services and sexual health promotion related services. But that is not a comprehensive list. That's just to give you a little bit of a sense as to what we normally get funding for. As well as you'll see on the slide, there is a dollar amount of $5 million, which is earmarked for what the province calls the Infectious Diseases Control Initiative. And this is a unit or a section within Toronto Public Health that has been established in order to address communicable diseases like COVID-19. This $5 million is over and above the $35 million that's provided generally to a number of the communicable disease control initiatives. And it's interesting that this funding was originally provided to Toronto Public Health and funded at a 100% level by the province for the purposes, and I will quote, of monitoring and controlling infectious diseases and enhancing the Board of Health's ability to handle, coordinate increased activities related to outbreak management, including providing support to other boards of health during infectious disease outbreaks. So that's what this fund was established for. And actually what's interesting about it is that it was established, as I recall, in response to SARS back in 2003. This funding, this $5 million funding for Infectious Diseases Control Initiative was 100% provincially funded prior to January 1st, 2020. However, as a result of the changes that you will be familiar with from last year, that funding formula was changed as of January of this year, such that it is now 70% provincially funded and 30% municipally funded. Turning to the next slide, to give you a sense of what the forecasted expenditures are in respect of the COVID-19 response. As you see on the slide, what we're forecasting for and what, again, figures are constantly rolling in respect of the expenses. this is what our current expense picture looks like for the period January 1st to May 31st. As you see, it lists $33.7 million, 28.7 of which is funded by the base budget and $5 million of which is related to extraordinary costs. You can see below that those extraordinary costs are broken down, largely comprised of salary and benefits. And this fundamentally is really about overtime for unionized and non-unionized staff who've been working additional hours in response to COVID-19. I'm sure you can appreciate that this is has been a very significant response on our part and has required hours and hours of additional work. Hence, you see these forecasts in respect of expenditures for that period of time, January 1st to May 31st. Turning to the next slide, taking us out through to the end of the year. As you can see, the projections now, based on what we know currently, and these are subject to change as the situation is constantly evolving, but based on what we can currently speak of and what we know of, it's $120.2 million that we're forecasting to spend in respect of COVID-19. As indicated on the slide, a goodly part of that is funded by the base budget, $24.4 million in extraordinary costs. And you can see that those are further broken down, salary and benefits for accounting for $21.6 million of those extraordinary costs, and a certain amount, $2.8 million, for a variety of supplies in order to support the work of those individuals. Here the numbers go up, here the costs go up, as you have likely heard through many of the communications pieces that we have put out to the public around our COVID-19 response. Toronto Public Health has brought on and has, redeployed some of our staff, but we've also brought on additional staff in order to support our case and contact management component of the response. In particular, a large source of additional staff and support for these aspects of the Toronto Public Health response have come through a partnership arrangement with the Registered Nurses Association of Ontario. So some of the costs, or the costs associated with that, I should say, are included here in this $24.4 million projection through to the end of the year. Turning to the next slide, what we're seeing overall is, and again, premised on what we know to date, is a forecasted funding shortfall overall of $13.1 million. And you'll see that this is lower than what you saw on the previous slide, around $24.4 million extraordinary cost. And the reason why there is a differential between that $24.4 million and the figure projected here at $13.1 million is that as a result of the COVID-19 response, we paused a number of programs and staffing initiatives because they could not be attended to at the same time as providing for this COVID-19 response. So there are cost savings as a result, and our understanding, premised on the communications that we've received from the ministry, is that any cost savings that have been accrued as a result of pausing programs and staffing initiatives originally seen and forecasted for part of the 2020 budget, those should be used to fund the extraordinary costs incurred for COVID-19. So when you look at this in total, taking the savings have been accrued as a result of not running certain programs, balancing that out with the extraordinary costs in the COVID-19 response, the end result is a forecasted funding shortfall based on what we know now, today, at $13.1 million for the end of this year. So turning to the next slide, let's now look at our current data and provide some information to you as the board on our response. Next slide, just a reminder as to what the objectives of the response to COVID-19 have been for us. These have been the objectives from the start, and they continue to be the objectives today. Preventing the loss of life associated with COVID-19, ensuring that we have capacity within our healthcare system in order to respond to COVID-19 activity, and as well to respond to other medical issues and conditions requiring the use of our acute care and other healthcare components of our system. And finally, to minimize the social and economic impacts of COVID-19 and the response to COVID-19, but as well thinking about the broader health impacts beyond the specific impact of a communicable disease per se. We need to think about, and have always been thinking about, the broader health impacts of COVID-19 and the response to COVID-19. Turning to the next slide, we have an infographic that gives you a high-level summary of that which is happening on COVID-19 cases in Toronto. These data are current as of the 6th of June. As you can see, our case count as of June 6th is 12,538, 9,623 of whom have recovered. Just to be clear, though, you will note, if you are following our numbers very closely, this case count did jump up significantly from the previous day. The reason why there is that significant increase in the number of cases was, you may recall, through what we have put out and through various media reports, there was an issue with a local hospital and laboratory and delayed reporting to local public health units. We were one of the local public health units that was most significantly impacted by that delayed reporting, and those cases have now been entered into the system. So there was a significant jump in our numbers recently, but it was largely due to a delay in reporting, as previously reported by us and through the media. Turning to the next page, this just gives you the specifics. It might be a little easier to read relative to that which was in the infographic. We know we continue to have COVID-19 circulating in our community. There continue to be infections arising. We are continuing our active case and contact management component of our response, and certainly the monitoring component, communicable disease surveillance, to ensure that we are providing our resources and affecting our response in those areas that are most relevant. As I mentioned on the previous slide, as of June the 6th, 12,538 cases thus far in Toronto, and other details are there for you to see with respect to how many are confirmed and probable, what our current state is with respect to the demand on acute care. I'm happy to say that those figures, hospitalizations, and those who are requiring intensive care unit admission continue to be declining over time, which is a good thing. But unfortunately, we have lost many of our community members to this disease. And at last count, as of June the 6th, the total there is 928. Turning to the next slide, to give you a sense as to what, at a very high level, the COVID-19 response has looked like for Toronto Public Health. As you can see at the top of the slide, we have redeployed over 1,000 of our staff. We have led additional recruitment because we have large functions that need to be addressed as part of our response. You can see that we've investigated clearly over 12,000 and are still in the process of investigating a number of those, more than 12,500 COVID-19 cases. To give you a sense as to the context and how significant that is for us, on any given year, we regularly investigate about 45,000 cases of all communicable diseases in Toronto. That's your typical year for us. And just for COVID-19 alone, in the last 3 months or so, we have investigated over 12,500. solely COVID-19 cases, and of course, that number continues to rise. We have answered, almost 41,000 calls from residents on our hotline and have investigated over 3,000 complaints related to a number of issues that continue to arise within the context of our city. While COVID-19 has occupied much of our attention and much of our resources, there continue to be other public health issues, of course, throughout our city. So as we continue to respond to the pandemic, we will engage, as I've mentioned earlier, on ongoing case management and contact management, and in support for outbreaks, providing appropriate public health support to outbreaks in our community. We are also providing public health guidance to the city, both in terms of COVID-19 response and as reopening and restarting various activities has also gone underway or started in earnest. We are providing guidance to that. And of course, scaling up key public health services as a result of that reopening and restarting of the variety of services and activities that generally characterize, if you will, regular life in our city. Looking specifically at the next slide, just to give you a little bit of a flavor as to what our case count has looked like and our epidemic curve. These are terms that are increasingly part of the public vocabulary. This gives you a sense as to what has been reported to us in the last 2 weeks. You will notice on the 29th of May, there's that rather tall bar smack in the middle of this graph. That is actually related to the data entry blitz, if you will, the increase in reported cases to us as a result of that delayed reporting issue that I've mentioned earlier. So it's not that there was a specific episode that preceded that, or in the days immediately preceding that. That's a reflection of when the reports actually did come to us as Toronto Public Health on that delayed reporting issue that arose from a local hospital and a local laboratory. Turning to the next slide, this is something that we first shared publicly about a week and a half ago, a neighborhood map demonstrating where COVID-19 cases in the last 3 weeks reside based on neighborhoods in Toronto, the 140 neighborhoods in Toronto. At a very high level, it's clear that COVID is having a differential impact on different neighborhoods. Not necessarily the case, though, that neighborhoods are high risk. It's actually incredibly important to make this point. But it's more of a question that people who have been most recently impacted by COVID-19 tend to live in certain parts of our city. This, I think, highlights a number of issues that we can discuss, how communicable diseases impact on certain populations in our city. And it certainly highlights the need for, to my mind, skilled case investigation so that we can actually get down to the root of where people are acquiring disease and why they acquire disease, so that we can move upstream in a very public health-oriented approach to prevent the source of disease and disease acquisition, including communicable disease acquisition. This is the role of public health. This is one of the major value adds in respect of case and contact management. There is a lot of emphasis on transmission of disease and preventing forward-going transmission of disease from case and contact management efforts. That is important. Do not get me wrong, that is an important part of it. But from a public health perspective, the area where we add unique value to the system, focusing on where and how people acquire disease, engaging in preventive activities to stop that from happening in the first place, is something that only public health can. Turning to the next slide, see that what we have presented here is something called a monitoring dashboard. And, to give you some context and sense as to why we have this, what I would like to inform the board of is that the response to COVID-19 on the part of Toronto Public Health has been and will continue to be informed by the best available evidence on the issue of COVID-19 and how it's transmitted and everything we know about it thus far. This is a new virus, as I've said many times. So we have to inform our response with the best available evidence. We also need to inform our response by our local data. So we have been following a variety of indicators to help inform our responses and our activities. It's come to our attention that this is even more important now as we are increasingly, as a province and in our city specifically, moving towards reopening and restarting services and activities that have had to be ceased for a period of time as part of public health measures to control the spread of COVID-19. With that reopening and restarting activity becoming more significant and more prominent, we feel it's important to provide a dashboard, something that our public can look at over and above us in Toronto Public Health looking at it and using it to inform our actions. We feel it's important that our public has a sense as to what we are seeing so that they can understand what is happening in our community and how our local data are being used to inform decisions around how to move forward and how we start to coexist safely as a city and as a community with COVID-19. I think it's important for the board to notice that the dashboard that we're proposing in order to communicate these ideas, these notions that we have been, and the work that we have been doing at Public Health since the beginning, actually do align with the provincial framework that was promulgated around reopening the province. It reflects the categories of indicators that the province put out in their plan to reopen the province. Turning to the next slide, we're going to go through the various components of the dashboard, the first part of which relates to virus spread and containment. So if we look at the next slide, what we're proposing to share with the public on an ongoing basis, and this will come sometime later this week, giving the board a bit of a sense as to what they can expect to see. We have a variety of indicators to help explain what is the current state on virus spread and containment. So what we're looking at here are, so what are we seeing in terms of COVID-19 cases? Are we seeing a declining a rate of new case onset in our city? What else are we seeing in respect of new hospitalizations? And what are we seeing in respect of COVID-19 outbreaks in institutions? These are the kinds of indicators that we use in public health practice in order to help inform our thinking on what needs to be done in terms of our response and how that should reflect in reopening and restarting discussions and decisions on the various services and activities in our city. Turning to the next indicator or the next category of indicators, what the province in their framework refers to as incidence tracking capacity. Next slide is largely around testing. So just to be clear, testing is an important component of the response, understanding who has COVID-19 in our community, identifying them so that they can be appropriately isolated and their contact followed up on, speaks to preventing forward-going transmission, the next generation of cases. From a public health perspective, as I mentioned earlier, it is also important for us in the context of case and contact management to identify cases and understand from where did they acquire their infection and what might we do as public health in an upstream fashion to arrest those sources of infection so that we don't create new generations of cases. But it's a much more upstream, much more preventive approach rather than just looking at who's already been exposed to somebody identified as a case and how do we stop them from spreading to the next generation. So this part of the dashboard is around testing. I will remind members of the board that testing, while it is important to public health action, is not actually run or within the purview of local public health. This is actually something that is managed through the province, and they have a network of laboratories, some of which are, the main one is the Public Health Ontario lab, but there are a number of labs that are part of hospital laboratory systems and some that are private labs that are working together under provincial purview to provide testing on COVID-19 for the people of Ontario. We know that there has been much focus on testing. What we have here as part of our monitoring dashboard is figures representing what is the turnaround time for a given test for COVID-19. So when somebody actually has a swab taken in the assessment center, that swab needs to go to a lab. How long, what this measures here, you'll see that it's the first two figures, the left-hand side of the slide and the middle, represent what is the turnaround time in the lab from the time that swab gets to the lab until you actually have a result and report it to public health. What is the turnaround time? They are aiming for clearly higher proportions of tests to be turned around quickly. Faster the test is turned around, the sooner that it's communicated to public health, and the sooner we can begin our part of the work of following up on those tests. So these data here show that most tests are taking quite some time to be processed. Only 23% of the tests that are done on Toronto residents for COVID-19 actually have a lab turnaround time of 24 hours or less. When we look at a turnaround time of 48 hours or less, it's 55% of the tests for Toronto residents as of June the 6th. So these are things we need to concern ourselves with. We are in regular conversations with our provincial partners around what can be done to improve these indicators. Turning to the next set of slides, the next grouping of indicators focuses on health system capacity. I'll just ask for the next slide to be advanced. We can see that this gives us a sense as to what's happening within our acute care and our healthcare system. There are goals indicated here on the screen, and you'll recall that one of the key objectives of the COVID-19 response was to ensure that healthcare capacity was preserved in order to address the needs of those who might actually become ill with COVID-19 or who have medical emergencies and needs that are outside, that are non-COVID-19 related. So ensuring that there are sufficient acute beds available for people should they need them for COVID-19 or for other illnesses. ICU capacity, ventilator capacity. These are important elements of ensuring that our healthcare system is ready to respond as needed. And on the bottom half of this slide, some of the important indicators that need to be followed is, and what is the available of personal protective equipment for those who actually work in acute care in order to manage patients, particularly those who have COVID-19 or other infectious conditions. We want to make sure that our healthcare workers in those acute care and other healthcare settings have what they need in order to respond appropriately. Turning to the next segment and section of indicators as part of our monitoring dashboard, this set of indicators focuses on public health capacity. If I can get the next slide, looking at public health system capacity, our indicators actually look at how quickly are we able to connect with either newly confirmed COVID-19 cases and also their contacts. So you will note here that with respect to reaching contacts within 24 hours of their identification, we are quite satisfied that we're doing very well in this regard. Our challenge has been in respect of reaching newly identified COVID-19 cases within a timely period. Our most recent data indicate that we were reaching just over 72% of our cases within 72 hours. of their identification. We have been putting a great deal of effort into this. You'll note there is a note here that it is this is unfortunately a figure that was we saw a decline in. We got as high as 88.7% late May, given all the many initiatives that we put into place. Unfortunately, we did see this decline largely due to that hospital reporting delay that I have mentioned earlier. But I think it's very important that the board remembers that one of the we have many challenges in this system. The way in which the results are reported to us, the delay that occurs within the laboratory system, there are a number of challenges that continue to need attention and need resolution from a system perspective. When those changes come into place, we're confident that we have put in a number of measures in place to help us get there. So even with system challenges, as you can see with the measures that we have taken at Toronto Public Health, we have been able to get us to just shy of 90% of all cases being reached within 24 hours of notification. And that is due to the really incredibly hard work that the team here at Toronto Public Health has put into addressing those system challenges. But the more efficient method of solving those challenges will be the system fix. We have temporized and we have found ways to address the current situations and the current challenges in the system. This is something that does require a system fix, and we'll talk about that in just a little while as we get to recommendations. So turning now to the next set of slides, and I promise I will try to move us along a little faster. Turning now to the Provincial and City of Toronto Offices of Recovery and Rebuild. I made mention of a provincial reopening framework. This is something that the province announced in mid-May, talking about principles on how to restore activities, reopen activities, whether we're talking about services, businesses, or public spaces. I did mention to you that there are 4 criteria that they are looking at underpinning those principles. They line up, and we have lined up our monitoring dashboard in accordance with this to make communications on this all that much easier. The province is currently has indicated that it will take a phased approach and will follow 3 phases to reopen and restart businesses, services, and other activities. And at this point in time, the province is currently in stage 1. Next slide. The criteria as put out in the provincial framework were relatively high level. A number, actually medical officers of health across the province, developed a set of indicators to provide a little more detail to the provincial framework. Again, in the notion and in aid of being able to communicate more amongst ourselves as local medical officers of health, and as well with the public that we serve. I think the issue that we're looking at here is how do we try to, we are looking at those objectives. I'll just remind the board that there are 3 major objectives of the COVID-19 response. Those continue to be the key objectives: to save lives, to preserve the capacity of healthcare system, to ensure that we're doing our best to minimize social, economic, and broader health impacts related to COVID-19. This is the kind of thinking that we are still deploying as we follow these indicators towards reopening and restarting. How do we make sure that any actions we take under restarting and reopening services ensure that we are doing our best to continuously meet those core objectives of our COVID-19 response? So turning to the next slide, I probably have gone ahead and started speaking about this. This slide articulates what I've just said, that we are continuing to focus our efforts on recovery and rebuild, on achieving the objectives that we set out for ourselves at the beginning of the COVID-19 response. We know that we have avoided what were projected as the potential number of fatalities, or predicted as the potential number of fatalities related to COVID-19 in our city. We have lost many, unfortunately, across our city. We know that we were able thus far to prevent or avoid what had been predicted in terms of the number of deaths in our city. We have thus far also managed to preserve the capacity of our healthcare system. And, our healthcare system to date has not been overwhelmed. But we need to continue to keep a watchful eye on both of these objectives and ensuring that actions we take not risk or jeopardize progress we have made on those two objectives. Finally, that third objective, it talks about social and economic impact on the slide. It is much broader than that. We do have to think about the broader health impact. But we do need to focus on this objective, knowing what we know of our current state, the city, and in the province. Turning to the next slide, know that the city's recovery and rebuild efforts will face a number of critical elements, and these are well described on the slide. Gradually reintroducing economic and social activities, recognizing that in so doing, there is risk. There is absolutely risk that happens as a result of reopening activity. But as I mentioned earlier, it's a question of trying to balance all the objectives that we've got in place, such that we can learn how to coexist safely with COVID-19, while at the same time mitigating any potential, ensuring that healthcare capacity is maintained, and ensuring that we are managing, the broader health impacts, the social impact, the economic impact. So what does that look like? We're talking about, yes, addressing recovery and rebuild efforts and reopening efforts through a gradual process, but at the same time, doing our best to mitigate risk and seeking to prevent transmission of COVID-19 as much as possible through a variety of different efforts: education, supports, monitoring, and clear and focused public health management on those areas that need it. Turning to the next slide, just looking at the provincial recovery stage 1, as I've mentioned earlier, we are in stage 1 of the phased plan. There are certain services that have restarted. Those are explained on the slide. We are, as part of this, working with the city's broader recovery and rebuild team led by Saad Rafi to ensure that public health guidance is in place to support city divisions and the various services that are out there for the city itself, for external business and workplace partners, and for community agencies to help them through what it looks like to resume operations in a safe way. Next slide. To be clear, we've brought on, as you've heard, Dr. David Mowat is supporting our work in this arena. And this gives you a little more detail in respect of the kind of work that David Mowat and the Toronto Public Health and other staff that are working with him are focusing their efforts and their time on. Providing guidance using the best available evidence around what are the risks to these various services and businesses reopening, and what mitigation measures might actually be taken in order to manage those risks as best as possible. There is general guidance being provided for a variety of services, both for the city and for partners outside of the city. There are, however, certain services, particularly those that are provided by the city and some other partners, that are very high risk or involve a number of complex issues. For those, and some are listed here: day camps, personal services settings, food premises, and restaurants. For those sectors, more specific advice is provided. And as you'll see on the slide here, for food establishments in particular, we are going to be providing very specific, and we have provided, it's actually already available online. There is some advice to support those businesses in terms of reopening safely, but we will also be providing additional supports by phone, online, and direct in person where needed for those businesses so that they can then reopen safely. Turning to the next slide, we are expecting an announcement sometime soon from the province regarding the next stage of reopening. It is difficult at best to anticipate, what the timing is that the province has in mind and which things they will be looking at reopening. But suffice it to say that in order to be prepared and in order to support our city and various businesses and services throughout the city to be prepared for announcements as the province makes them, provides details on their timing, we are continuing to develop public health guidance in as informed a way as we can. We are providing advice and observing the best available evidence and using that best available evidence to provide our best advice on how best to manage risk, whether it's through physical distancing, on cleaning, on how to use appropriate protective devices, including masks. So we know that as of last Friday, the province announced an extension of their emergency order until June 19th, but we are expecting, further announcements on the next phases of reopening very shortly from the province. Mr. Chair, I'm just going to go through the last slides. We're just about reaching the end, and I do thank you all for your patience. The final component of the presentation has to do with the recommendations that are listed in the report. I won't belabor the point. Much of all the points are actually articulated in the reports. A little more detail on the slide. Looking at recommendation 1, next slide. I have spoken to this already in the presentation. I've spoken to how our case and contact management efforts are unfortunately currently challenged by a number of issues related to the transfer of information, how information moves from laboratories to Toronto Public Health. This does create delays. Hence, we have included, and this just gives you a sense, this little schematic gives you a sense as to where delays do occur. Further details are available in the report, but suffice it to say that there are system issues that we have implemented organizational solutions, interim solutions to address as best as possible, given our current circumstance. However, the ultimate solution for a system issue is a system fix. Hence, I propose this recommendation that the Board of Health and City Council make an ask of the Ministry of Health to create that system fix, an efficient system to transfer information so that public health can spend its time doing the things that it needs to do, case and contact management, both in terms of preventing further transmission and in terms of understanding acquisition and putting prevention measures in place, rather than spending its time doing fixes in order to discern what information we've received and how best to tease it out from the very complex morass that we actually receive at this point. Turning to the next slide, this is just to give you a sense as to the COVID-19 testing strategy. This is relevant to recommendation number 2. The next slide will focus on that. I have indicated to the board that the province is responsible for COVID-19 testing, and they are also responsible for the provision of guidance. What we have heard much about through the popular media has to do with the number of tests that are being performed on any given day. And while ensuring that sufficient testing capacity and that sufficient testing is occurring, most important is actually figuring out how best to deploy testing resources as a means to reduce transmission of COVID-19. So testing is part and parcel of a strategy and approach to support and to be integrated with case and contact management. Hence, the next slide speaks to the need for a clear and consistent approach to COVID-19 testing, and that's what gives rise to the recommendation that I'm putting forward to the Board of Health and to City Council. A clear strategy that is really premised on objectives, very clear objectives, and the best available scientific evidence needs to be undertaken. And, to be fair, this is a new virus. We are still learning a great deal about this virus. There is much that we do not know. But I think that speaks even more to the need for clear strategy that is evidence-informed. Turning to the next slide, recommendation 3 in the report refers to local recovery indicators. They're listed as recovery indicators here and in the recommendation. While they will inform the recovery, I would encourage that we look at these as monitoring indicators. It's about ensuring that we have, we're using appropriate local data to inform our overall response, which includes understanding how best we reopen and restart our services. And this should be done informed by the best available evidence and, of course, informed by our local data as indicated by the monitoring dashboard, keeping in mind that it is always about the objectives, saving lives, reserving and preserving the capacity of local health care, and as well ensuring that we're doing what we can to minimize social, economic, and broader health impacts of COVID-19. And finally, the last slide, recommendation 4, has to do with ensuring that we have the resources that we need in a very coordinated and timely way to support the response. Again, very evolving situation, virus that's new, changing information on a regular basis, sometimes on an hourly basis. I've put forward a recommendation that City Council requests that the City Manager work with us at Toronto Public Health to develop what we're characterizing as enhanced approaches to provide more coordinated support. Just given the rapidity with which things are evolving, we actually need more timely methods by which to ensure that we have the resources on a variety of fronts, as you can see here: human resources, legal, information technology, amongst others, to effect a timely and effective response on behalf of the people of Toronto. So with that, I will wrap up my presentation. I will thank you all for your patience and your support over these past many weeks. I am very conscious of the fact that just this past Saturday, we marked 19 weeks since our first case of COVID-19 here in the city of Toronto. It has been, as I've mentioned at the last Board of Health meeting, an incredible and very challenging journey, I would say, for us as an organization. We have, really been flat out since the beginning of this year. I would be remiss if I did not acknowledge, one, the support of you as the Board of Health, with a special nod to our chair. But perhaps even more importantly, I would like to acknowledge all the staff at Toronto Public Health. A few special acknowledgements to our senior management team here at Toronto Public Health, who have been working unbelievably hard, 7 days a week, really, for many, many weeks now. And in particular, I would just like to give a special nod to Dr. Michael Finkelstein, one of my colleagues here, Associate Medical Officer of Health and Director of our Communicable Disease Control area, our directorate. He has been incident managing this response since January and done Herculean work over the last several weeks. And I just think it's worth the board knowing that. So with that, thank you again for your patience and time. I'm very happy to take any questions that people may have when the time is appropriate for that. Turn it back to you, Mr. Chair, and thank you.
Thank you, Dr. Davila, and thank you to members of the public and the board for allowing Dr. Davila, to provide such a comprehensive report. I know it was long, but the issue warrants it, and thank you for your attention. We're going to move this into public speakers. We have 2 registered speakers. The first is Dr. Jeffrey Schiffer from the Native Child and Family Services of Toronto. Jeff, welcome. Once we have you on the line, you'll have 5 minutes, and I'll start a clock for you. Do we have you there, Jeffrey?
Yes, I'm here. Is my audio coming through all right?
We can hear you loud and clear. So when you're ready, you can begin. You'll have 5 minutes, and then we may have questions from you from members of the board. So over to you, Jeffrey.
Phenomenal. Thank you, Mr. Chair. I just want to start by acknowledging the phenomenal leadership of Dr. Davila and thanking everyone at the Board of Health and at Toronto Public Health for the response that we have witnessed at Native Child and Family Services of Toronto throughout the city. We are overwhelmed by the support that we have had in supporting Indigenous children and families. I'm here today to talk a little bit about some of the COVID response and the impact that COVID-19 has had on some of the most vulnerable children in our community. And also just to reflect on this a little bit in the context of our National Indigenous History Month. We know that June is National Indigenous History Month, and we may all know that there's a very long history of disease for Indigenous people. Disease epidemics is nothing new for Indigenous people. And we have seen across generations that ways in which Indigenous people respond to and deal with epidemics is often through trauma-informed land-based practice. I think what we have witnessed over the past 3 months plus really is the removal of a lot of face-to-face prevention services that vulnerable Indigenous children and families in our city rely on. For over 3 months now, we've had Indigenous children at home, not going to school or being seen by daycare. And we all know that there are great impacts due to that. I was really happy to hear the focus on broader health impacts, and I wanted to talk a little bit about what that has been like for Indigenous people. I think one of the other hats that I wear is I'm honored to be the vice president of the Association of Native Child and Family Service Organizations of Ontario, which is an association that brings together all of the Indigenous Children's Aid Societies across Ontario. Our group has really benefited from the opportunity of having ongoing meetings with a group of medical doctors and social workers and academics from Italy to learn a little bit about their process. And one of the things that we really heard from them was the impact that children and their communities were feeling due to restricted access to green space. For me, this prompted a partnership that we've recently embarked on with Dr. Barbara Fallon at the University of Toronto and Dr. Stephen Miller, one of the heads of neurology at SickKids Hospital. We started looking into a little bit of the research, and it's really clear that ongoing access to green space and playing outside has a really fundamental role to child development and holistic health for children and youth. We're also starting to see this in some of the research, in fact, that's coming out of Italy and Spain, where parents are reporting that very high numbers of children are having trouble concentrating. They're dealing with boredom, irritability, nervousness, lots of social anxiety. In fact, Right to Play released a recent study of about 6,000 children spanning the US, Germany, Finland, and Spain, showing that over 65% of children were struggling with social isolation, anxiety, depression. And so, as a local director of child welfare and an advocate for some of the most vulnerable children in our community, I think that when we talk about broader impacts of health, we also need to think about what the long-term impacts on children are going to be. And some of the most vulnerable children in our community are Indigenous children, right? And so I think it's also incumbent upon us to think about what reconciliation looks like in the context of COVID response. I can tell you that through the work that we do at Native Child, we really do understand that trauma-informed land-based practice is innovative. And I know that, or you may not know, but it's important for us to recognize that, Ontario is the most populous province or territory when it comes to Indigenous people in Canada. And at any given time, 20% of that population is right here in the city of Toronto. So we have a massive urban Indigenous population. We also have over 1,500 parks in this city. There is no shortage of green space here. And so I think that as we plan for our COVID response and recovery, we need to think about how service agencies like mine can partner with the city to provide access to green space for vulnerable children and families. We've designed a number of scenarios at Native Child that would enable us to put a single worker with a self-isolating family outside. And so we're hoping that the Board of Health and Toronto Public Health would take interest in that and work with us to make that happen. Mr. Chair, in conclusion, I'll just say that if we can find ways for the most affluent members of our community to play golf, I have the absolute confidence that we can come together to create access to green space for the most vulnerable children in our communities. Thank you. Miigwech.
Miigwech, Jeffrey, and that was a pretty stellar conclusion. So thank you for that. Let me check if there are any questions from members of the board of Jeffrey here. I just have one, Jeffrey. And I know when you mentioned it that you've been working closely and in active conversations with various city departments in Parks, Forestry and Recreation, and TPH, and the Aboriginal Affairs Office. Are we getting close to the model, approval for the model in the city's parks that you're looking for? From those conversations, do you feel we're close?
I would say that we are quite close. And so we're also working with the province. We're very close on both fronts. And I think I've got a follow-up conversation with Selena and hopefully Janie from Parks or someone else this week. So I think we're getting very close. I think the final hitch maybe is thinking about whether or not we actually need to permit these spaces or just provide a letter to show bylaw officers. And then really what we need on the Toronto Public Health side, and if we can get approval to do things like bring in portable washrooms and hand washing stations and the kind of things that we would need to be able to ensure health and sanitation through the delivery of these services.
Well, thank you, Jeffrey. And I know Councillor Layton and we've spoken last week, I think, with you on this, and we'll stay on it this week together. So thank you. Any other questions of Jeffrey from members of the board? Yes, Peter Wong. You'll have 5 minutes. Over to you, Director Wong.
Thank you, Mr. Schiffer, for your presentation. My question really is around what other, the UN Child Rights for Children commit to play as well as recreation, but also to listen to the voice of children and to hear what they're saying, and also to give them information. As the leader of your organization, what are our Indigenous children saying about COVID and isolation during this COVID-19 period? Thank you.
Thank you very much. So through the conversations that our child and family well-being staff have had, our social workers with families, and also some of our clinical and early on staff, right now most of our engagement is happening through virtual services and checking in with children at home through FaceTime and other video conferencing means. We're hearing that we're hearing what's being reported in the data that I referenced. We're hearing that children are feeling isolated, anxious, often some feelings of depression that they don't identify with, which our clinicians are saying may relate to some of the intergenerational trauma aspects that we know Indigenous children are facing in this context. And they want to get outside. They're lonely. They want to see their friends and they want to get outside. We know that it's not the right time to start getting kids together from other households, from different households, but we're pretty confident that we can get them together outside with workers that they have relationships with to manage some of these needs and support their holistic health and wellness. Thank you.
Thank you. Director Wong, any further questions?
Thank you, Jeffrey.
Are there any further questions for Jeffrey from members of the board? Okay, seeing none. Jeffrey, thank you so much. Look forward to chatting again soon. Our next speaker is Kevin representing Cycle Toronto. Do we have Kevin on the line?
Hello?
Kevin, we hear you loud and clear. Welcome. You'll have 5 minutes when you're ready.
Very much. Good morning to the members of Toronto's Board of Health. My name is Kevin Rupasinghe. I'm speaking to you today on behalf of Cycle Toronto, a nonprofit, member-based cycling advocacy organization working towards a safer, healthier, more vibrant city. First, of course, I want to thank everyone on this board and those working in Toronto Public Health. People across Toronto have been looking to your leadership over the past several months, and your tireless efforts have done so much good. So we are very grateful for the actions you've taken. the many lives you've saved, and the time that you've bought us all. I'm here today to talk about the COVID-19 response and its impact on transportation. As you know, there was recently a first phase of active TO, which has been a crucial set of interim measures to provide people more space to walk and bike safely while maintaining their physical distance to curb the spread of COVID-19. These quiet streets and major temporary street closures, they have had immediate success in making the city more livable through the pandemic. And we certainly urge the city to expand these programs to more equitably reach Torontonians in all neighborhoods. And further, the set of cycling projects that have been accelerated are important ones. The 40 kilometers of bike lanes that are being constructed within the next month, these will provide safe transportation alternatives for hundreds of thousands and leaves more space on transit and more space on our roads for those that will continue to take transit and drive. And this is to everyone's benefit. So it's really crucial that these first set of active TO projects are implemented successfully. And it's clear, I think, that more will be needed. Torontonians across the city are affected by virus, and all of them will need access to safe alternatives to get around as the city reopens. But in fact, we now know that this virus doesn't impact Torontonians uniformly. The shoulders of our city, where the virus is hitting the hardest, remain places that only transit and only driving, if you can afford it, are viable, as they've received no pandemic response cycling infrastructure. And it's fair to ask, how is this fair for those essential workers in those marginalized communities to remain with fewer transportation options throughout the pandemic? So as the province and city move towards reopening, we know that more people will be straining our transportation network, more people will start to go to work, more people will take non-essential trips, and very soon the TTC is going to reach its 30% or so capacity limit, after which they can't have customers maintain their physical distance. We have the good fortune of being able to predict and anticipate this outcome. So why would we wait for this to happen before we act? Why wait for a future COVID spike to occur on a bus or a subway that's too crowded because we failed to give people safe alternatives, such as cycling, to get around? And, Dr. Davila, as you said today, public health is uniquely positioned to take preventative action and to mitigate these risks inherent in the restart of our economic and social life. Public health has also said before, it's the virus that dictates the timeline. We don't have the luxury of waiting longer to prepare. It's imperative that we begin planning a phase 2 of active TO projects now, so they're ready to roll out later this summer once phase 1 has been installed. And there's reason for this urgency. It's not just about cycling. This is about a crucial component of a pandemic response plan, and work on phase 2 has to begin at pandemic speed as well. This includes projects like the other side of the TTC Line 1 along Yonge Street, which is the busiest subway line in the city and country. It can't continue to serve as many riders as it used to, and we need a safe cycling alternative so that shorter local trips can be safely made by bike, and that leaves capacity on the subway for those taking longer essential trips. There's also many suburban bus routes that connect communities to employment centers. They're filled with essential workers and people doing essential trips. They also need relief. Phase 1 of active TO had nothing on Yonge, had nothing in Midtown, nothing in Etobicoke, and just the beginnings of a cycling network in North York and Scarborough. So more is needed to ensure we have a comprehensive pandemic response. You've all played a very crucial leadership role over the past few months and done so much for Torontonians and bought us so much time. We're really counting on your leadership to ensure that these efforts were not wasted because of an inadequate pandemic transportation response plan. We're counting on your leadership to ensure that a phase 2 of active TO is rolled out later this summer so that people across Toronto can have a safe and healthy way of getting around during the pandemic. Very much.
Thank you very much, Kevin. Appreciate it, and appreciate all of your work leading up to last week's council vote and continuing today. Are there any questions for Kevin from members of the board? Seeing none, Kevin, thank you very much. We're now going to move that's the end of our registered speakers. We're now going to move this internally or into committee for questions of staff. And Dr. Davila is here, as are other members of her team. I believe Dr. David Mowat, I see, is here, Althea Hutchison and others. And so, why don't I get a running list? Could you put up your hand just to indicate if you have questions, and I'll put you on a speakers list. I see Councillor Perks, Director Mulligan, Others who have questions, Director Wong Tam, Councillor Wong Tam. Okay. So, making a running list here. Okay, so I have, just so people are aware in terms of the order, and feel free to decide if you have questions later, but I have Councillor Perks, followed by Director Mulligan, followed by Director Peter Wong, followed by Councillor Wong Tam, followed by Trustee Donaldson. And if you have questions, feel free. After I run through that list, we'll put others on. So, Councillor Perks, you are first. Over to you.
Thank you. To the Medical Officer of Health. So you mentioned in your presentation that we had reduced certain programs that in order to move money over to funding work on COVID. Is there a list of which programs have been reduced or cut? By how much?
Through the chair, Councillor Perks, I don't have the complete list in front of me, but I'm certainly happy to provide that to you and the members.
Okay, that would be helpful. I'm correct in understanding that any reduction that we have made are deducted from how much money we can ask the province for. In other words, if we canceled a program in order to move staff over to dealing with COVID-19, cost savings are realized by the province of Ontario.
Yes. So effectively what they have, through the chair, what they have asked us to do is in respect of any extraordinary costs that were incurred as a result of the COVID-19 response, we are expected to use our existing budget amount or existing dollars that have been provided to us through our budget, or then going to the province and asking for additional funding. However, we are communicating on a regular basis with our provincial colleagues on what our costs to respond to COVID-19 look like on an ongoing basis.
Okay, thank you. That's helpful to know. I've seen that medical officers of health from across the province have suggested that we need to have a regional approach to reopening. So given that Toronto is its own health board, we could be in a situation where the province recommends that we reopen something province-wide. Our judgment might be that we're not ready to do that. Is that correct?
So through the chair, that is theoretically possible. And to my mind, the province is at liberty, I suppose, to make its own pronunciations and announcements. They do have, and as you know, wield quite a bit of power. That being said, as you know, I have a responsibility, and together, with the board, we have a shared responsibility to ensure that what happens in Toronto is what makes the best sense for residents of Toronto insofar as protecting their health. And as far as COVID-19 is concerned, the focus is on ensuring that we're best positioned to achieve the objectives that I've outlined.
Right. So as I understand it, the province has emergency powers to make these changes, but you also have statutory powers and responsibilities under the Health Protection and Promotion Act. If they issue guidance on all the restaurants, or I think they're today announcing something about extending patio hours, are you able to use your authority under the Health Protection and Promotion Act to say, well, we're not ready for step X, Y, or Z here in Toronto?
So through the chair, this is an interesting question. I will tell you that I've had many conversations over the course of the last several weeks with council. Will tell me that, and they have advised, there are certainly powers that are accorded to me under the Health Protection and Promotion Act to deal with very specific risks, very specific health risks. The challenge is that and there are precedents that talk about how medical officers of health are supposed to use those authorities and powers. We are not meant to use those powers in a way as to circumvent policy-making processes, but to control specific risks. So I don't know that there is a very simple or straightforward answer to your question. However, if there are specific identified risks, there are powers under the legislation that I can use to help control those risks, but I am not meant to circumvent policy processes or the broader democratic processes that are in place.
Right. I understand that. And that's always a balancing act that anyone with statutory authority has to be aware of. So let's suppose the province issues something. What are the steps that would happen if, for some reason, there was evidence that that would create a risk in the Toronto situation? How does that mechanically work?
So through the chair, if there is a particular step or course of action, let's say, that the province wants to take, in our estimation at Toronto Public Health, does not make sense from a health perspective for Toronto. And one, clearly we would have to articulate and establish the case for that in Toronto Public Health. Presumably this would require the use of local data, the best available scientific evidence, those kinds of things that inform our decision-making processes here. Have to put that together into a case. I would certainly engage our legal counsel to understand how best we might deploy our authorities or my authorities and powers under existing legislation, and come up with different options on how to address that circumstance. So it may be through the use of orders or using powers under the existing Health Protection and Promotion Act. I suppose other options would include having very clear negotiations or conversations with provincial counterparts to delineate. Again, there is a chief medical officer of health of the province as well, who also has responsibility. And of course, there are local medical officers of health around the province, particularly those in the Greater Toronto and Hamilton area. They face very similar circumstances. We often have very complementary or similar challenges and issues in respect of serving our populations that differ quite a bit from jurisdictions that are more remote. So I think there are a number of avenues that we would pursue. Which one we would actually pursue in a particular situation will depend on the circumstances, but I hope I've given you some sense as to what we might be able to do in the event of the kinds of a situation like you described.
Councillor, we're over 5 minutes. We may come back for a second round if that's okay. Thank you, and we'll entertain a second round given the important topic in front of us. Next, I have Director Mulligan. Director Mulligan, when you're ready.
Thank you, Mr. Chair. Dr. Davila, I wanted to follow up on Councillor Perk's line of questioning and ask particularly around masking advice. Do you have the authority to require universal masking or just recommend? And also, what is your perspective on the role or relevance of universal masking?
So through the chair, first, thank you for the question. Having had significant conversation with a number of local public health and broader public health providers and with legal counsel, it is my understanding that the best I can do in my position is to strongly recommend or make recommendations around mask use and other such provisions. We have been advised that it is more of a policy decision to make, in the broad sense, mask use, cloth face covering a requirement amongst the public. So that is our current understanding right now. With respect to what the current evidence base is in respect of masks, this is a fascinating question and one that continues to be the subject of much debate in the realm of public health. What's well understood in the realm of public health is that the best protection that is provided right now is physical distancing, creating space between oneself and individuals outside of one's household. With respect to masks, there are a lot. We know that I won't go into all the great details. When it comes to proper medical grade masks, there's lots of evidence for their use and their protective benefit to those who work in healthcare settings. The public, however, the evidence continues to be unclear. There are a number of studies that are out there of varying degrees of quality. But this is still a very hotly debated topic in the realm of public health as it applies to COVID-19. New virus, still learning a lot. So you will hear all kinds of opinions. It's, I think, as I said, there isn't a clear answer. Save and exclude for the benefit of physical distancing and the protective benefits of physical distancing. It is unclear as to whether masks provide extra protection. Our current understanding is that at the very least, they may prevent your transmission of germs to other people, probably not as good in terms of protecting oneself from the germs of others.
Thank you. I also have a couple questions about the data and reporting. So, we're hearing a lot about outbreaks in congregate settings, and I know Toronto Public Health reports on some of those, like shelters and long-term care facilities. Is there a plan, and do you have the data about other congregate settings like group homes for people with developmental or physical disabilities, mental health facilities, Toronto community housing, and or informal congregate settings like rooming houses in apartment buildings?
So through the chair, we do engage and support outbreaks in a number of those different settings. I don't have a complete list for you today, but as part of our work in managing outbreaks and clusters, we certainly do provide support to those various settings. When we detect clusters or outbreaks in those settings, we are working with a variety of other partners. It's not exclusively us. We have to engage with healthcare partners in order to provide the complete range of services, not least of which involves testing. Is
there a plan to report publicly on the data from those facilities to help us disaggregate what community transmission looks like?
So I will check with the team around what what the specific plans look like. I don't have an answer for you, unfortunately, at this moment in time. I do think that there are a number of endeavors underway with respect to how best we understand community transmission. And in particular, we are very interested in understanding acquisition and how we get further upstream with respect to stopping, it's an earlier preventive activity rather than focusing on cases and who they've already exposed. Understanding where individuals have acquired their disease and engaging in appropriate preventive strategies is another area where I know we're actively investing some resources and effort.
So on that note about who is at risk, can you provide an update, please, about the collection of sociodemographic and race-based data, how that's going and what action is being undertaken right now?
So through the chair, as you know, we have actually included, and it did take some time to provide to make changes to our data management system. You may recall through the previous board meeting that I spoke to the need for us to create a new data collection case management system to support our COVID-19 response. We had to add those elements. We were interested in pursuing the collection of sociodemographic data as part of our COVID-19 response. Those changes, the technological changes that were required to the system, were, I believe, implemented a few weeks ago. I'll have to think through when the exact date was, and I do apologize for not having the specific date in front of me. We are collecting those data, and I'll have to talk to the team about how soon we might be able to start reporting on that. Certainly, we wanted to ensure that we have collected for a sufficient period of time before we actually start reporting. But I will check with our data team on what the plan is and get back to you.
And Director, we're just over 6 minutes. So we're going to move on to our next questioner, but I'll come back if there's a desire for a second round, if that's all right. Thank you. Next up, I have Director Peter Wong.
Thank you, Mr. Chair. First of all, I really want to compliment the Toronto Public Health staff on the immense amount of work they've done over this COVID-19 pandemic. I also want to compliment the Medical Officer of Health and her senior staff, especially, as you mentioned, Dr. Michael Finkelstein. The health communication has been outstanding, and that's obviously in part because of the Medical Officer of Health, but also our board chair. So congratulations. My question is around this blip in cases. I think that the referral to a blip is underestimating it, because it seems to be over 400 positive cases who went unreported, and obviously these 400 cases were out in the community and no contact tracing was being done because we weren't aware of them. I know Dr. Davila has alluded to there are systemic challenges, but maybe can you allude a little bit more about what, expand on the measures that we have done at the local level within the realm of Toronto Public Health to eliminate or decrease the risk of further miscommunications happening? Thank you.
So thank you through the chair. That particular issue that happened with the hospital and the laboratory, I don't know that we can do much about it per se. Suffice it to say that there was much communication, and all the labs and hospitals were made aware of that very, very unfortunate circumstance and oversight on the part of those individuals. And I can tell you that for a period of time shortly after that discovery was made, we were receiving an incredible amount of lab tests. It seems to me that the labs and the various assessment centers who were doing the testing, when they heard of the challenge that happened with that particular hospital and lab, checked their own files and then sent a number of different follow-ups to us at Toronto Public Health, which actually created more of a challenge to us. I won't go into the details. I don't want to use up all your. Suffice it to say that there are the way in which laboratories report to us is very complex. It's complicated, and it's frankly outdated, and it requires a system fix. What we have had to do on our side is to ensure that are providing as many staff as possible to manage what is a very labor-intensive process of separating out individual lab slips. We have put in more people to follow up on incomplete information that is received. We cannot contact people if we don't have relevant contact information to reach them. We have put in measures in place to ensure that we have a greater number of case and contact follow-up staff to effect that important work. And we are working with laboratories and with assessment center partners. We've initiated a number of different pilots with them to find ways to facilitate the transfer of information and to reduce the time from when somebody actually gets symptoms, gets tested, and when we actually get the result in a coherent and comprehensive fashion so we can follow them up. But I do know that with respect to that delay in reporting, all the labs and assessment centers were made aware of that and that by the province, and there was follow-up with each and every one of them to ensure that it was patently clear who is to report and that they are in fact reporting.
Dr. Davila.
Thank you, Director Wong. Any further question? Okay. Next, I will move on to Councillor Wong Tam.
Thank you very much, and for you, Mr. Chair, I'd like to ask about the recovery efforts and the planning for the recovery, especially as we move into phases. With respect to strategies to ensure that we can continue to keep people safe, are we anticipating how are we preparing for what happens if we have another outbreak? How we're in the midst of reopening the economy?
So through the chair, thank you for that question. I think there are a number of different aspects that are involved in that response. What we're trying to do is make sure that we have appropriate strategies in place, trying to solve issues around ensuring that testing is is broadly available and available to those who actually need it, to make sure that we have appropriate case and contact resourcing, and trying to address those systemic issues for which systemic fixes are needed. But until those come, we have to make sure that we are putting whatever we can to addressing those circumstances. Certainly as well, I have been having active conversations with a number of partners, including healthcare partners. They will have to be actively engaged in dealing with and responding to surges in activity of COVID-19. But I think fundamentally what's most important here, what I would describe as a gradual and phased approach, reopening and restarting over and above the work that my colleague Dr. David Mowat and the team here at TPH that has been tasked with the recovery work, if you will. We have put in a number of mitigation efforts and strategies and guidance to those sectors that we anticipate will be restarting and reopening services over time to try to minimize the potential for cases. But I do think that it will take a very concerted effort across the many different streams of activity in order to ensure that we're able to monitor and prepare for potential surges. I think we have to recognize that there is risk. There is risk to not reopening and not restarting, and there is risk associated with reopening and restarting. How do we balance these risks together? We do it in a gradual, careful fashion, constantly monitoring what.
Attorney General today has announced that there are plans to allow for the relaxing of the of patio extensions, that they are going to permit what they're moving towards the regional reopening. If Toronto is the GTA is the hotbed and where we're seeing the greatest number of transmissions, we will most likely be at the end of the recovery. So we'll be the last to open. And then within the city, there'll be phases of different types of businesses that will be even further delayed in reopening. Dr. Davila, at what point in time will you or the other health professionals make the call that if an outbreak does take place, a second wave, that you'll then pull back the economy again? So we go back into sort of that lockdown that we've all been in. Is there a lever that triggers this?
So through the chair, Councillor, I don't know if I can give you a specific, signal. It is actually taking into consideration the various indicators that we know of, the monitoring indicators, in order to understand what is happening. Have to look at the objectives of the response. How do we balance all these objectives appropriately, and what levers, as you say, do we need to deploy and use in order to get the best effect? Want to ensure that we're able to minimize the direct impact of COVID-19. We also want to make sure that we're allowing for circumstances that best address the challenges that we've just heard from one of our deputies, the social isolation. There are economic and broader health impacts also associated with keeping a relative lockdown, if you will, on a variety of services and activities in the city. something that we're going to have to monitor and utilize the best available evidence and our best judgment in respect of what makes the most sense for the health of Torontonians. And I will further suggest that because there are a number of other jurisdictions who are ahead of us in terms of their outbreak experience, having started their COVID-19 outbreaks earlier than ours did, we have the opportunity to learn from other jurisdictions and deploy the lessons that they've learned in our circumstances, and we will do that.
Thank you, Councillor. Next up, I have Trustee Donaldson. Trustee Donaldson, when you're ready.
Thanks, through you, Chair. So thanks for this report. Thanks so much to you and all of your staff for your ongoing Herculean efforts, as you described them before. And I also want to thank all my colleagues for their excellent questions so far. So I have a question related to the current provincial approach to testing and specifically to public communications. And I just want to give you an example of what happened last week in the Toronto District School Board. We received a letter from the Minister of Education, and it was about COVID testing. And the Ministry of Education directed school boards across the province to send this letter out to their communities to describe what Ontario's approach to testing is and talk about how to get it. So one thing that caused me a great deal of concern about this was that, number one, there didn't seem to be any coordination or space and time for coordination with local public health units. And the other thing that I found very concerning was there was one bullet in the letter that seemed to differ from what the province's existing direction was on testing. And that was a bullet that said, basically, anybody who wants to be tested can be tested. So seeing the work that was displayed in the report on the case and contact tracing that Toronto Public Health is doing, I have a few questions. Number one, why would the province be issuing health-related communications outside of the Ministry of Health? This one was coming from the Ministry of Education. And I also will say that in the TDSB alone, we have 250,000 students, 40,000 staff. You multiply that by the amount
Trustee,
of that are.
I just want to make sure you give time to Dr. Davila to answer the question.
Yeah, I'm getting there. And the reach that in the TDSB is probably close to 1 million people. So my first question is, why is the Ministry of Education issuing health-related communications? Why would a health-related communication on COVID not provide the space and time for local public health to provide input into it? And if Toronto Public Health wasn't made aware of this communication and it produced a spike in the community from both questions to Toronto Public Health and more testing, what impact does this have on Toronto Public Health's ability to respond? Thank you.
So through the chair, I'll try to go through an answer to each of the questions. I can't speak to why the Ministry of Education would be pining on this issue. Happy to follow up with our provincial counterparts and understand what might have happened there. I am not, myself, I was not aware of that communications. That may be more reflection on me than it is on what the ministry did or did not do. I certainly am happy to follow up with our staff to understand whether we did receive specific communication on what was provided to school boards. However, the impact of testing, I think that's why you have a recommendation in front of you in respect of this report. Testing strategy, is actually incredibly important. Testing is not the be-all and end-all, and certainly if it's not just focused on numbers. We need to make sure that testing is done as part of an overall strategy to best control COVID-19 and prevent COVID-19 in our communities. Hence, we put forward a recommendation for your consideration, and I do hope that the board will see fit to move forward with this recommendation, because I think it will go a long way towards addressing your question. And towards ensuring that we're best positioned to provide a good response as
Agreed. I was really happy to see that recommendation. And I think you are a great example of what really strong public communication looks like on public health matters. So thank you very much.
Thank you very much, Trustee Donaldson. Next up, I have Councillor Lai. Councillor, whenever
Thank you,
you're
Mr.
ready.
Chair. Can you hear me okay?
Yep, we have you loud and clear.
Yeah, thank you. Thank you, Mr. Chair. Through you, I just have a few quick questions for Dr. Davila. And first of all, about yesterday, there was a resident complaint about people that are playing soccer in the park just behind the house, and they are not really practicing social distancing. And called 311, and 311 said it's taking up to 2 days for them to kind of follow up on these things. As a medical officer of health, what is your best advice for residents like this, that can see that people are not really observing the rule for social distancing, physical distancing, because, you said that this is the best way to prevent this virus. So just wanted to hear from you, what is the best way that a resident can do, even that they find somebody who's breaking the rule?
So through the chair, thank you for that. Seems more like an enforcement issue, and I don't know that I have any special knowledge in and around enforcement. However, we have spoken at length throughout the response that when we can provide people with information and offer them reasons as to why they should adopt certain behaviors, we hope that people will choose to adopt those behaviors. It helps if we can give them to help guide them through such things as, say, for example, the circles that were painted in a place like Trinity Bellwoods Park, being markers and indicators to help people make the right choices and support the best choices to control COVID-19, I think is part of that. And certainly putting out the message that physical distancing continues to be the best way to prevent ongoing infection and to protect oneself, one's family from COVID-19 infection. The only other thing I can offer is that at the very least, this risk, I should say, is lower in outdoor environments. However, that doesn't take away from the importance of physical distancing. I can certainly raise the issue with my colleagues who are more actively engaged in the enforcement area of activity, but in public health, we prefer to focus where possible on how we can actually support people to choose to do the right thing, to engage in those behaviors, whether by choice or whether it's just easier for them to do the right behavior.
Okay, the other question I have for you is that recovery efforts, I think, is very important that we minimize the potential of the second wave. And on council last week, I think there was a motion about the Pearson International Airport. I just wonder what strategy and what actions are you taking as public health when the U.S. border opens? I mean, are we prepared for that, or what actions are you planning on taking now? I mean, for the anticipating the opening of the border.
So through the chair, when it comes to the management of the border and the airport, whether we like it or not, that is actually outside of our purview as Toronto Public Health. While Pearson does serve Toronto, it is actually technically located in Peel Region. And on top of it, anything that has to do with border activities, border screening, and travel restrictions and the like actually falls to the federal government. So we are engaging in conversation. My understanding is that our provincial government has been made aware of the impending changes and is having conversation with the federal government around the borders. I expect that they will be inviting many of us who are expected to be impacted by these kinds of decisions to conversation. I shall keep the board informed of that, but I will just remind members of the board that our role here is one of influence and discussion, as the jurisdiction over the border and the airport fall to the federal our federal counterparts.
Thank you. Those are my questions.
Thank you, Councillor Lai. I'm going to put myself on the list. Can I just see, by way of a show of hands, anybody else who hasn't asked a question who wants to be put on the list? Just want to see any new. And can I check in terms of, because I'm conscious of time, but is there anybody who would like a second round? I'm going to put myself on. I see Councillor Perks would like to come back on. Anybody else? Just, okay. So I'm going, and then I have Councillor Perks, and then we're going to move it into committee. In for conversation. So Dr. Davila, hello again. At our last meeting, you talked about two pandemics. The first being travel-related cases, the second that we were seeing in congregate settings. Recently, you've talked about the emerging pandemic, which disproportionately impacting people on low incomes, people who are visible minorities. I'm wondering when we expect to have a deeper dive on the data TPH is collecting on that related to those who are most particularly at risk today.
So thank you for the question, Mr. Chair. I don't have a specific date for you. As I mentioned in response to an earlier question, changes needed to be made to that case management system in order to allow for the systematic collection of those data. I know that our data team are very keen on putting out information as soon as we accumulate enough information that warrants and allows us to actually put out public information. This is something that we're very engaged in, and we will do this as soon as we can.
So there is, and I've advanced circulated it, an amendment or a motion that I'm moving requesting that at our next meeting in 3.5 weeks, that TPH share with us what updated data we have collected with a focus on occupation, workplace status, people who are housed or underhoused. Is it realistic to assume that we will be able to get an update with a deeper dive into that data and that disaggregated data by our next meeting?
So I believe we should be able to provide you with some aspects of a deeper dive. I don't know that we will have everything fully worked up for you, but we will certainly do our very, very best to provide you with as much information as we can.
Okay. And then if we are seeing a disproportionate impact in neighborhoods that are predominantly low income and with a high percentage of visible minorities, I'm wondering whether you and TPH are considering additional measures that we may seek to employ, either as TPH or as the city in partnership with other governments. For example, accommodations for people who have a home but are underhoused, large households with one washroom, for example, or additional measures targeting at certain workplace settings where we're seeing high rates. Are additional measures, additional preventative measures for situations like that under consideration? Is that something TPH is thinking about or would consider bringing recommendations on at some point?
Yes. In short, yes, of course, led by the data and the best available evidence on the subject.
Okay. On contact tracing, and I know you've gone through the work that TPH has done to date and the increase in staffing working on this on case and contact management, that is, from 50 to nearly 600 today. On the data, so help me understand this. Somebody gets tested. After they are tested, we only receive the positive result a couple days later. And the form in which we receive that result is not electronic. It's often through fax or e-fax. Is that right?
So to the extent that e-fax can be described as somewhat electronic, but yes, that is exactly how we receive it.
Okay, so I know there's, as a reopening, an indicator for reopening has been set that public health units are to be in touch with somebody 90% of people who test positive within a day. Is that right?
So it's to achieve contact reach new cases, 90% of new cases within 24 hours of us being informed of their positivity.
So that's where I want to drill down. So it's for us to be in touch with new contacts, 90% of new contacts within a day, but that only starts at the point we receive the data. Is there a
is
target?
correct.
So is there a target that of what percentage of new positive cases would be provided to public health within a day?
So there is a target for the labs to turn around a result in 24 hours, 60% of the time.
So the target is 60% of the time for them to turn it around in 24 hours.
That is correct.
And what percentage of the time are we currently receiving it within 24 hours?
So the turnaround time in the laboratory that we I believe was just 20, let me just make sure I've got it. As of June the 6th, 23% were turned around within 24 hours.
Okay, so public health units, well, Toronto Public Health, we're only receiving a positive lab case within 24 hours, under 30% of the time. So your recommendation here calls very clearly for a system-wide improvement across all the disparate labs that exist for consistent reporting, consistent information to report and to do that. I guess the question I have is, just as we built our own CORS data system to upload data to the province, could TPH, system-wide would be better, consistency would be better, I get that, but could we not just, if time is an issue and it's not getting done, could we not build our own portal? Could we just go and build our own portal and ask the labs and the hospitals to follow us with our data fields in real time electronically?
So theoretically, that is possible. It would require significant engagement with the labs as they are processing not only COVID-19 results, but a number of other tests are being processed through those labs. So I would say in theory that's possible. Whether practically that could be done in a timely fashion and whether that would be the most timely approach, I think would have to be explored with our lab partner.
Okay. And then my just final question on reopening. You went through in your presentation the detailed indicators for reopening that you and the other medical officers of health have established. And you also went through a draft dashboard that I see in the presentation. Is the intention to share that dashboard publicly and on a regular basis once it's finalized?
So yes, I'm sorry if I did not make that clear through the presentation. Our plan is to make our monitoring dashboard publicly available and regularly update it so that we can use it as a communications tool to support that which we're telling the public.
Right. And do you have a general ballpark of when we're hoping to make that publicly available?
Our plan is to release that at some point this week.
Okay. Those are all my questions. Thank you so much. Final questions we have, and then we're going to move it in for remarks, is to Councillor Perks.
Thank you. Dr. Davila, we've heard a few things that are quite disturbing to me. The turnaround time for the testing isn't there. We've heard that don't have a lot of clarity about how congregate settings in the city of Toronto outside of long-term care, group homes, rooming houses, personal care rooming houses are not being supported well enough. I think we also need to acknowledge that the City of Toronto, through Toronto Community Housing, provides more housing to low-income people than, frankly, anyone else on the continent. Given all of this, given that the GTA region seems to be consistently showing higher numbers of cases than the rest of the province of Ontario, I'm quite at sea here. I don't know that we're in a position as a Board of Health to comfortable with these reopening steps being taken. Now, I've asked and got something of an answer about how you're doing it internally. We on the Board of Health have an obligation too. I'm wondering what you could propose that we as Board of Health members should be doing to satisfy ourselves that these steps are being taken in a safe way.
So through the chair, you raised some very good questions, and I certainly appreciate that the board has, its obligations to discharge appropriately to the citizens of Toronto. With respect to just talking about the group settings and TCHC, while there may not be yet readily accessible data on what we're doing, we do have a number of work groups and activities and relationships that are established with these partners, and we are deploying on a very operational point of view cluster detection algorithms to understand whether we are seeing, and this is all sort of the guts of communicable disease investigation and understanding our data. So there are a number of initiatives that are happening here in the operations in Toronto Public Health to understand what is going on in different settings within our. So I would like to assure the board of that. I think one of the challenges as well that we need to think about in understanding our data and the numbers of cases, very challenging to understand exactly what's happening. I'm hoping that we're going to get a little more stability and clearly a better testing strategy around, for the province, because with the fluctuation in the number of tests that have been done and with a drive towards increasing testing, the reality is that we will see more cases just by virtue of doing more testing. And finally, what I would say is that you will have heard many of us argue or put forth an argument for the need to actually pay attention to our monitoring indicators in order to inform decisions around reopening and restarting, so that we can actually, as a system, and certainly for the City of Toronto, ensure that we are doing the best we can in keeping with our local data, in keeping with the best available evidence on COVID-19 to achieve our objectives, to save those lives, to preserve healthcare capacity, and to ensure that we're doing the best we can to minimize the broader impacts of COVID-19, social, economic, broader health impacts, rather than just focusing only on COVID-19 and controlling and preventing COVID-19. It is a much broader perspective that needs to be brought to bear, and it will involve some degree of restart and reopening for some of the reasons that we've discussed already through this meeting.
Changing gears for a second, one of the pieces of advice that I've seen many times is that there has to be some method to discourage employees from coming in to work when they're sick as we begin to reopen. You share that?
Yes, certainly. Staying home when sick is an important component.
The province of British Columbia has made it mandatory that employers provide paid sick time as a measure to stop the spread at workplaces. And we've seen a lot of evidence that the spread takes place among people who are low income and precariously employed. This was some of the problem that we saw in long-term care. Do you think it reasonable that employers be required to provide that paid sick time?
So through the chair, that's an example of an approach that is consistent with a public health manner in addressing issues, right? Making good health choices easy for people to engage in. So helping people stay home when they're sick by ensuring that income is not impacted is clearly a public health approach to a situation like COVID-19, amongst many others.
Thank you.
Thank you, Councillor Perks. We're going to move this in for speakers now. Can I see by way of a show of hands who would like to be put on the speakers list? Okay. Okay, and I have Councillor Lai, Councillor Perks, Director Mulligan. Anybody else? Trustee LaPretti. And I will put myself on as well. Councillor Lai, you're first up. Over to you.
Thank you, Mr. Chair. First of all, I'd like to actually echo everybody by saying that we really appreciate the phenomenal job that Toronto Public Health, especially Dr. Davila and your team, who has contributed to this COVID-19 pandemic. And I just wanted to quickly remind ourselves that I do get it when we know it's all about education and all about influencing our residents to make sure that everybody is safe and the damage for our city remains very low. And now we're actually trying to prevent the second wave and all that. And everybody has a role to play. And I do get it when there's sometimes, the federal governments and the provincial government, there are issues that are under their purview. And I think the City of Toronto Public Health should take a more proactive, very proactive role in ensuring that we are safe, respect to working with the provincial and the federal government. I know that we are doing it. We are really in dialogue with them every day, and we are doing a good job. And just give an example, at the beginning of this pandemic, I did raise a question about the federal borders, and to a point that I think if we could have done it more, earlier, that we wouldn't have so much cases in Toronto. This is just in hindsight, but I think we should all be getting ready and to be proactive and to take the leadership in ensuring that Toronto will become one of the safest cities and in Canada. And we do have a very high population, and I think it is our job to really protect our community from all these, from the virus. So I just wanted to wish everybody healthy and please stay safe. And we're into this together. We'll get through this together. And we might come out of this a little bit different, but I think all in all, we are doing a good job, trying our best to make sure that we can combat this virus. Thank you.
Thank you very much, Councillor Lai. I have Councillor Perks, followed by Director Mulligan, followed by Trustee LaPredi. Councillor Perks, when you're ready.
Thank you, Mr. Chair. I want to begin by acknowledging that the tremendous work done by Toronto Public Health staff and the medical officer of health. I think it's important to always keep that in mind when we're thinking about all these issues. But I do want to express deep concern. Concern because the province of Ontario essentially is putting us as Board of Health members and our our medical officer of health and her senior team in a very difficult position. There are standards for test turnaround, which is a provincial responsibility, that are not being met. I can tell you from working with some of the operators of personal care rooming houses and other congregate settings in my ward, while they're doing and data monitoring for those sectors, they have been struggling to get any kind of assistance to make sure that they can implement safe measures. Remember, many of these places are badly underfunded to begin with. I also note that today the province of Ontario has just announced something to expand patio hours. As the City of Toronto, we have more patio, than anyone else. I also note that the number of cases in the City of Toronto has persisted at stubbornly high levels compared to other parts of Canada. Putting all that together, I'm at a loss here. Don't have the medical officer of health said it would be good if there were ways to protect the income of people who were sick so that they would stay home from work. We don't have that here. Over and over again, the province of Ontario has put us in a position where they have hastened and rushed to reopen things, even though the standards that any reasonable person would expect for management of the COVID outbreak are not being met. Now, I understand we're meeting again in 3 weeks and hope at that point to have more information. I also understand that the medical officer of health has undertaken to provide members of the board with information on what programs we've had to curtail in order to save the province of Ontario money. But I'm getting extraordinarily frustrated, and I'm prepared to wait another 3 weeks before we really push back. But if we're not seeing the province of Ontario taking the advice from medical officers of health about what the conditions of reopening should be, we're going to have to take more dramatic and drastic action.
Thank you, Councillor Perks. Next, I have Director Mulligan. Director Mulligan, when you're ready.
Thank you, Mr. Chair. I want to support the motions that are on the table with respect to our COVID-19 ongoing work. And I do want to restate how critical it is for us to have information that is transparent and accountable. We need to know what's happening when we hear community transmission. We need to know who in our communities are at risk, and we need to see the reporting from informal and formal congregate settings beyond what is currently being presented to us. It's my understanding that the Ministry of Children, Community and Social Services does have data, but for some reason it's not interfacing with Ontario Health or other healthcare systems data, or it's not being reported. We don't have public access. And I think many of the frustrations voiced by Councillor Perks and others on the board have been really illustrative of how fragmented our response has been and how we need to find better ways to work together, and we need to do that now. I'm very appreciative of Toronto Public Health for sharing some of the initial area level data about who's been made vulnerable and the underlying social determinants of health, including racism, poverty, and inequity, that are really putting some people at much higher risk than others. But those maps can't tell the whole story, particularly in very diverse communities that show, downtown areas where very wealthy populations and very poor populations are together. So we need disaggregated data, we need local data, and we need that data to help support local community agencies and health service providers to do the work of testing that Dr. Davila has pointed out. It shouldn't be the work of public. So I want to restate how critical it is that they have the data. The data can't just sit at public health or in provincial ministry offices, but the people who are responsible for doing the testing and providing trusted wraparound supports and care for people who may not trust mainstream health systems or governments. It's really vital that they have this information and that they have it now. And so I'm going to continue to look for those data to guide any decisions that we as a board can support or make with respect to reopening. And until such a time as we have that data, we are operating blind, and I agree that there are some risks. So I also look forward to hearing more information at our next meeting. Thanks.
Thank you very much, Director. Next, I have Trustee Lepretti. Trustee Lepretti.
Thank you, Chair. With regards to the active TO and the return to school planning that is going on, and we consider all public health parameters. There's one particular one that we haven't discussed yet. It's about school busing. School busing discussions continue with the TCDSB and TDSB Transportation Consortium and exploring a number of different scenarios in how we're going to get our students back to school in September, if they do go back to school in September. And with the new reality, there is much discussion about busing for students. Where a bus that would usually hold 65 students, we would only be able to fit around 14 safely in accordance with, in order to adhere to physical distancing models. So I would like to ask that what we need to do is we need access to safe alternatives instead of busing, which are essential to get students, their parents, or caregivers to and from school safely. So I fully support the expansion of the program, the bike program, and I'm hoping that adding alternative ways to include bike lanes around school communities in particular are a focus.
Thank you very much. Trustee Lepretti, could I just see by show of hands anybody else who would like to be put on the speakers list? Okay, seeing none, I will speak. I will start by placing an amendment which has been advance circulated. If it can be posted online here. Specifically, it's to request our medical officer of health to report and make a presentation to our meeting at the beginning of July in 3 weeks on the latest steps taken on the response, case and contact management improvements, and the status of the coordinated systems with the lab, a continued analysis of the socio-demographic data, and the latest findings regarding who is at risk, including assessing housing status and occupation, recommendations based on those findings on enhanced protections for those who are most at risk, including a consideration of accommodation options for people who have a home but cannot properly isolate in their home due to, for example, inadequate living spaces. There are also amendments here requesting Minister of Education to consult with local public health units on communication, to request our medical officer of health to produce, as she has indicated is the plan, and regularly update a dashboard on recovery indicators, as well as to request the city to work with the John Howard Society to ensure that their critical assessment and support services for people leaving incarceration are continuing to operate. So that's the amendment in front of us. Let me first of all thank Dr. Davila, who cannot be thanked enough for her 19 straight works of leadership, hard work, and compassion with the weight of the world on her shoulders, to the Toronto Public Health team, all 1,800 of them, from our AMOHs right on down. They are working flat out and have embodied public service at its very best. And to members of this board for your relentless work and leadership. I will tell you on a personal level, and I speak to all of you often, that I would be lying if I didn't tell you that the last 19 weeks have been, for me, the most challenging, has been the most challenging period of my life. And like nearly everybody in this city, whether you're a frontline worker or a resident just trying to make it staying at home, or whether you're working on the front lines, everybody's drained. I, frankly, am exhausted. But our residents, Toronto's residents, in particular the most vulnerable, are counting on us. And so while this marathon may never end, we must continue to sprint through it. There's nothing else we can do. The story of this pandemic, and let me make a few brief comments on the story of the pandemic, the testing and contact tracing system we have in reopening. If this were a 3-act play and we were entering the 3rd act, I would say that the 1st act was travel-related cases. We saw that. The 2nd act was congregate settings. Those who live in congregate settings and are most vulnerable as a result of them. Seniors care, long-term care, shelters and respites. The act we are in now, and the act that I am deeply concerned we are going to continue to be in for a long time, is, the only way to put it, is an assault by COVID-19 on the most vulnerable. The working poor, the underhoused. Diseases have always preyed on the most vulnerable. COVID-19 has taken severe advantage of that. And I'm deeply concerned that unless we as all levels of government understand who is most at risk, the workplaces where they earn their living, the housing status, often the underhoused housing status where they spend their nights, unless we understand that and proactively get in front of that, we will see more people sick and more people die needlessly. It's not new that diseases prey on poverty. The social determinants of health, race, income, housing have long determined who lives, who gets sick, and who dies. But I'm not convinced that at the provincial level, we know who's most at risk, and I'm not convinced that collectively at the municipal and provincial level, the measures are in place yet to protect them. On contact tracing and our case management and investigations, this pandemic has exposed very clearly that the provincial infrastructure to deal with a pandemic of this scale did not exist. It has exposed that when you fail to invest proactively in public health infrastructure, when a crisis hits, harm is done. And so for the first 3 months of this pandemic, testing was not where it ought to be and we were flying blind. We now have testing capacity, though as our medical officer of health has recommended here, we actually need a clear strategy with testing to guide the implementation. Success is not measured in 20 or 22,000 people being tested every day. It's are you testing in the right places and the right people to guide your response. That's success. On contact tracing, I'm deeply proud that at Toronto Public Health, Eileen and her team have managed to move a team from 50 people up to 600 people. 600 people working on case and contact management. To put that in context, the second largest public health unit in Ontario, in Peel, has 700 staff. Our case and contact team is now the largest in this country. We developed our own core system to upload data to the province. That's impressive. We have not been without our own mistakes and challenges, and we have more to do. But when we have a system, as we do right now, where public health, local public health units, us included, where we only receive 23% of lab results within 24 hours, when the results we do receive lacks key contact information, often as simple as a phone number, and does not include occupation and housing status information, and when there's no central system for us to receive results, in fact, we get them by e-faxes, faxes, phone calls, handwritten notes. This is not a workable model in a pandemic. So imagine, in the midst of a global pandemic, at Toronto Public Health, we receive positive cases days after people find out they're positive, and then we spend a day trying to find their phone number to contact them. That is not effective case and contact management in a provincial system this complex and in a scenario this important. And so the solution is and must be continuing to human resource and staff up our process and system as we are, but an actual 21st century centralized and real-time data system to actually provide information from the labs to public health in real time and with the actual information, not just to contact them, but to have the occupation and health-based information and congruent institutional information to track emerging problems. Let me conclude my remarks on the reopening. We know that certain areas, especially in the GTA, face clear challenges and unique challenges. And I'm proud of the work that our MOHs here in Toronto under Dr. Davila, but also in Peel and Halton and Durham, have done coming together to create criteria for a regional approach. That hard work and big lift has had impact. The province has indicated they are now supportive of a regional approach. I'm concerned that test numbers have plateaued in terms of case counts. I'm concerned, as I've said, about the impact on the most vulnerable. I'm also concerned about the effects of an indefinite lockdown and the severe social and economic effects. Reopening carries risk. We are living with a virus that is circulating. When you reopen, there will be cases, there will be outbreaks, there will be deaths. We have indicated and developed here at TPH clear criteria to guide reopening. We're going to have to monitor this and scale up if this is going to work. Let me conclude by saying that this unprecedented moment in our history is in front of us, and it's a test that we must meet as a board, and we must meet it by responding well and mitigating harm, but fundamentally by building a new and better normal. And we have two big tasks, and the work continues. With that, I'll conclude my remarks. In front of us, we have staff recommendations and an amendment. Is there a desire for a recorded vote, or can we take the amendment and the staff recommendations as a package? If you would like a recorded, if you would like a recorded vote on the amendment, could you raise your hand to indicate so? If not, we'll take them as a package. Councillor Layton, you would like a recorded vote on an amendment? No. Okay. Okay. So we will take it as a package, the amendment and the staff recommendations. Is there a request for a recorded vote on the package? If so, could you raise your hand to indicate so? Okay. Seeing no request for a recorded vote, all those in favor of the motion as amended as a package, all those in favor? Director Peter Wong, I see your hand up. Okay. That is everybody. That is unanimous. Thank you very much. Okay. We are now moving on to our second item, Our second item is HL 17.2, Toronto Overdose Action Plan, Status Report 2020. We have a staff presentation followed by deputations. Let me indicate, as it's now noon, I suspect that the presentation followed by deputations may take us to 12:30. I would suggest that just before 12:30 we see how far along we are, and if there is a desire to proceed and carry on to finish or break for a short lunch. So why don't we begin, and we'll see close to 12:30 what our timing is. So we will begin with the staff presentation followed by the speakers, and I believe we have Susan Shepherd here from the Toronto Drug Strategy Office. Is that right? Who's giving the presentation?
Yes, that's correct, Councillor Cressy. Thank you. You hear me okay?
I can. Susan, you've never called me counselor before. Let's stick with Joe.
It's the first time for everything.
There you go. So we have a presentation here. Susan from Toronto Public Health. Susan Shepherd, over to you.
Thank you. Good morning, everyone. I'll be providing you with a brief overview of the Toronto Overdose Action Plan Status Report 2020, which is before you today. This annual report is part of our accountability on implementation of the Toronto Overdose Action Plan, which was endorsed by the Board of Health in March 2017 and updated last year in June. The report highlights key actions taken over the last year and makes recommendations for further action, especially in light of the COVID-19 pandemic. I do want to acknowledge that this work represents the collective efforts of Toronto Public Health and other city divisions, diverse community and institutional partners, people who use drugs and family members, and it's important for us to acknowledge that collective effort. Next slide, please. Start with, I'd like to provide you with some data about the opioid poisoning crisis. In Toronto, there's been an alarmingly high number of deaths caused by opioid poisonings over the last 3 years. Preliminary data reveals there were at least 295 suspected opioid overdose deaths in 2019. Please note this includes probable and confirmed cases, and the number is expected to change as coroner investigations are completed. This graph clearly shows the unprecedented increase in opioid overdose deaths since 2015 and continued on into 2019. In the province, there were 1,535 suspected opioid overdose deaths in 2019, and that number is expected to change as coroner investigations are closed. Next slide, please. This graph shows the number of monthly suspected opioid overdose calls attended by paramedics between August 2017 and May 2020. These numbers have fluctuated over the years with periodic surges seen in August 2017, the summer of 2018, and March to May 2019. There's also been a surge this year between February and April. 2019, paramedics responded to over 3,000 non-fatal calls and 141 fatal calls. During the first 5 months of this year alone, paramedics have responded to almost 1,500 non-fatal calls and 96 fatal calls. Slide, please. To the scale on the previous graph, which is a bit hard to decipher, I want to bring your attention to the number of fatal calls attended by paramedics so far in 2020. Over the past 3 months, paramedics have attended a higher volume of fatalities due to suspected opioid overdose. Though the number of overall calls attended decreased in May, the number of calls with suspected fatalities have remained high. You'll see that both in April and May, they attended 25 fatal calls in each of those. Next. You've seen with the data, the opioid poisoning crisis remains a serious public health issue for our community, and it's further compounded by the COVID-19 pandemic. These dual public health crises are having negative impacts on people who use drugs in our community, their friends and family members. Services that people have relied on have temporarily closed or reduced their service hours and or capacity during the pandemic, including harm reduction and treatment services. Unregulated drug supply is increasingly contaminated with unexpected drugs and toxic substances that put people at further risk for overdose. We don't have enough safer supply programs which would reduce the risk of overdose and support people to stay home and self-isolate if necessary. Criminalization continues to force people into unsafe behaviors, and putting someone in jail and prison puts somebody at further risk for contracting infectious. such as COVID-19. Next slide. In terms of action taken over the last year, we continue to advocate for decriminalization. Most recently, the Toronto Drug Strategy Implementation Panel joined others to urge the federal health minister to decriminalize possession of drugs for personal use during the pandemic. A similar recommendation is before you here. Last year, the Toronto Urban Health Fund provided funding for 22 community-based overdose prevention initiatives and peer outreach. Toronto's first drug checking service began in October. An analysis of samples from October to March confirmed that the unregulated drug supply is contaminated with highly potent compounds, increasing the likelihood for overdose and other adverse reactions. Continue to work and develop and maintain relationships with Indigenous organizations to support implementation of the Toronto Indigenous Overdose Strategy. This included identifying and sharing funding opportunities and helping develop and promote overdose awareness events specific to Indigenous communities. We've convened a diverse work group of experts to develop strategies to support women who use drugs to keep their children. A key focus at the moment is developing guidance for community agencies helping women involved in the child welfare system to maintain access to their children during pandemic-related closures and restrictions. Next slide, please. Also, Perks, who chairs the Toronto Drug Strategy Implementation Panel, facilitated the process with Toronto Community Housing, Toronto Public Health, community organizations, and people who use drugs to draft a new and more robust harm reduction policy for Toronto Community Housing, including overdose prevention measures. And that policy will be eventually going before the board of TCH. Also, Dr. Davila joined with Chief Executive Officers of Unity Health, Women's College Hospital to create the Toronto Academic Health Science Network, or TASN, and Toronto Public Health Opioid Task Force. This task force is developing a proposal for seamless healthcare for people who use drugs as they move between hospital and community-based services. At the moment, the group is developing a proposal for virtual treatment and healthcare during the pandemic. Also, we have worked hard to increase our communications to the community through regular emails, social media health promotion, and issuing drug alerts to flag urgent issues for the community. Next slide, please. A number of recommendations before you today, some of which reiterate some positions you took at the last board meeting. They include recommendations urging the federal health minister to use the existing authority under the Controlled Drugs and Substances Act to decriminalize the possession of all drugs for personal use. Also to increase funding for safer supply programs, including funding Toronto Public Health's application for an injectable hydromorphone program. We're also seeking support to support knowledge exchange and capacity building related to overdoses involving benzodiazepine, which are resulting in overdoses that are very difficult to route. Slide. Recommendations directed to the Provincial Minister of Health include convening an opioid task force to oversee action at a provincial level. In the previous government, we did have such a task force, but haven't had one since, and we need that coordinated effort. We're also looking for support for safer supply programs, including putting the necessary medications on the Ontario Drug Benefit Formulary to allow physicians to prescribe. We're also asking them to utilize a class exemption provided by the federal government to allow for the opening of more supervised consumption services and overdose prevention sites during the pandemic, as well as to look at some alternative models such as virtual or phone-based witnessing models to support people in their housing, because we know one of the highest factors for death due to overdose is using drugs alone. We're also looking for support to provide funding to treatment and harm reduction services to help them comply with all of the new requirements for their programs and services resulting from COVID-19. And an ongoing standing issue that we've flagged before is funding grief and trauma supports for frontline workers and others impacted by this dual health. Slide, please. The court also makes a recommendation to the Office of the Chief Coroner for Ontario to really look at whether COVID-19 is a possible contributing factor to opioid overdose deaths, because both opioid overdoses and COVID-19 suppress the respiratory. We want to learn more about what might be happening. Also, looking to the Toronto Central LHIN to expand funding for existing crisis services to allow for more comprehensive range of services for people who drug. Slide, please. Closing, I would like to emphasize that Toronto Public Health remains committed to working with our community and institutional partners to improve our collective overdose prevention and response, which is even more critical this time. Thanks very much.
Thank you very much, Susan. We're now going to move to speakers before bringing it into committee. Our first speaker is Richard Elliott from the Canadian HIV/AIDS Legal Network. Richard, thank you so much for holding with us all morning. Do we have you there on the line?
I'm here. Can you hear me?
We can hear you loud and clear. Thanks again for your patience. Richard, you'll have 5 minutes whenever you're ready.
Thank you, Mr. Chair, and thanks to Susan and the Toronto Drug Strategy Secretariat and the Medical Officer of Health for the report and the recommendations. As mentioned, I work for the Canadian HIV/AIDS Legal Network, a national organization based here in Toronto that has for many years worked to defend and promote the rights of people living with HIV and of communities that are particularly affected by HIV, which obviously includes people who use drugs. I should start by noting that we fully support all of the recommendations that are made by the Medical Officer of Health in her report, including those aimed at increasing access to harm reduction services, safer supply, and various treatment options. I want to speak today specifically to Recommendation 1A, the recommendation that the Board of Health urge the Federal Health Minister to use the flexibility that exists in the Controlled Drugs and Substances Act to remove the criminal prohibition on possession of drugs for personal use. I should note that we differ slightly from the recommendation as put forward by the Medical Officer of Health, only insofar as that in our view, it is important for this decriminalization effort not to be limited to just the duration of the COVID-19 pandemic. Of course, the pandemic provides yet another reason to remove the harmful prohibition and its enforcement on the simple possession of drugs. But even if COVID-19 were to be resolved tomorrow, there would still be a compelling case to decriminalize simple possession of drugs. In fact, I want to recall for you, as has already been noted, that in 2018, you as the Board of Health, in fact, already called upon the federal government to decriminalize the simple possession of drugs for personal use. Obviously, that has not happened yet, but there is a growing demand for change based on the evidence that continues to mount that criminal prohibition of drugs and its enforcement is damaging to public safety, to public health, and to the public purse. I refer you to a report from the Canadian Centre on Substance Use and Addiction in 2018 that reviewed the growing body of evidence supporting decriminalization. And I think it's clear that in the last years, the ongoing overdose crisis, and now in recent months, the ongoing COVID-19 crisis, are only heightening the folly of continuing to treat drug use as a criminal law issue rather than a health issue. What you have before you is a recommendation to support a very specific proposal that is now before the Federal Health Minister in keeping with your earlier recommendation to decriminalize simple possession of drugs. I'd like to draw your attention to the document that I provided to the City Clerk last week, and you have before you. It is a letter from more than 140 organizations across the country. Additional endorsements continue to come in, and they represent a wide cross-section of civil society putting forward to the Federal Health Minister the very specific proposal that she use the power as Federal Minister of Health that she has under the Controlled Drugs and Substances Act to achieve the decriminalization of simple possession of substances for personal use. You may know, and as you can see in the full text in footnote 8 of our letter, Section 56 of the Controlled Drugs and Substances Act gives the Federal Health Minister the power to issue an exemption to any class of persons in relation to any substance or class of substances that are controlled under the Controlled Drugs and Substances Act from any or all of the provisions of the Act. You will be, of course, familiar with this provision as it is the power that has been used to facilitate, among other things, supervised consumption services and overdose prevention sites. Now, this is an action that the federal government could take right now without having to go through a lengthy process of legislative amendment in Parliament. and the prospects of it doing so are increased by the support of municipal governments requesting an end to the use of police resources for enforcing prohibition on simple possession, a prohibition that does no good and much harm. I want to just draw to your attention the data available from Statistics Canada. It's not mentioned in the submission, but in 2018, there were more than 83,000 drug arrests in Canada. 2/3 of them in that year, that is more than 55,000 arrests, were for possession offenses. For the last 5 years, for which data is available, between 2/3 and 3/4 of all drug arrests were for simple possession. On average, over the last 5 years, more than 70% of arrests for drug offenses were for possession. Toronto, in 2018, there were more than 6,700 arrests for drug offenses. This means if we apply the national average, because we don't have city-specific data on this at this point, in Toronto alone, between 4,400 and 4,900 drug arrests were made for possession offenses.
And Richard, just to let you know, you're just over 5 minutes if you want to wrap up in a sentence or two.
Yeah, thank you. What we know is that the criminal law and its enforcement also disproportionately affects Black and Indigenous communities. And if in this moment we want to redirect resources away from the harmful policing of our communities, then reducing the use of those resources to enforce simple possession charges would be a very good way to do so. This call is, as you can see in the letter, endorsed by a wide range of organizations, and I would invite the Toronto Board of Health to reiterate to the federal government its support for decriminalizing simple possession, and specifically the proposal that we have laid out about using the flexibility in the statute that currently exists. Thank you very much.
Thank you so much, Richard, and thank you for holding with us. Are there any questions for Richard? You have a question if you want to indicate. Okay, seeing none, Richard, thank you so much. Our next speaker is Gary Thompson. Do we have Gary on the line?
Yes, you do.
Yes, you do. Gary, welcome. You'll have 5 minutes. You can begin when you're ready.
Thank you. Good morning, brothers and sisters. City's recommendation 1, Part C, urge the federal government to support evidence-based knowledge exchange and capacity building responses that reduce the harm from benzodiazepines and opioids. C, online INCHEM, INCHEM. Part 10, the management of poisoning and drug overdose. Benzos are a respiratory emergency, along with opioids. Quote Deputy Sarah, May 7th, Board of Health. Standard overdose is respiratory intervention, such as rescue breaths. Millions taught deny rescue breaths, give chest compression. They eagerly follow orders, putting every Canadian's life in mortal danger. What many fail to mention, rescue breaths is essential any breathing emergency caused by injury or illness. Health Canada removed rescue breaths from their protocols October 2018. Go avoid ventilator shortage. Deny rescue breaths, non-overdoses, and ODs needlessly in ICU on a ventilator, permanent brain damage, oxygen deprivation. 50,000 poisonings per year in Ontario. 28,000 are children. Over 1 million people per year in Ontario taken to hospital, given respiratory assist. Many are repeat COPD, asthma, etc. Less than 15,000 out-of-hospital cardiac arrests per year in Ontario. Signs of cardiac arrest are totally different than respiratory emergency. Needless trauma, workplace harassment and bullying increases mental and physical illness, drug use, misuse. Earlier, Dr. Wong's statement to Deputy Jeffrey, UN Declaration quote, listen to children. Child knows, breathe or you die. I am showing up on scene on a regular basis, parents giving their live children chest compressions, non-ODs. Those that say it can't be done should not interrupt those that are doing it. George Bernard Shaw. Thank you. That's the end of that.
Thank you very much, Gary. Are there any questions for Gary? Okay, seeing none. Thank you very much, Gary. Our final speaker, I should tell people, Dr. Jeanette Bowles from St. Michael's Hospital was unable to stay on the line and has submitted a correspondence which is online. So our final speaker is Angie Hamilton from Families for Addiction Recovery. Do we have Angie on the line?
Morning.
Good morning,
Can you hear me?
Angie. We can hear you loud and clear. You'll have 5 minutes and you can start when you're ready.
Thanks for the opportunity of addressing the board. I'm the Executive Director of Families for Addiction Recovery, or FAR. FAR was founded by parents whose children have struggled with substance use disorder, or SUD, from their early teens. FAR exists because the needs of our families are not being met. We expect our children to receive treatment, not punishment for being ill, and that rarely happens today. FAR supports Dr. Davila's recommendations, and we want to speak to the need to decriminalize the possession of drugs for personal use and safer supply. Susan Shepard and Richard Elliott are hard to follow, and we support everything that they said. It's painful to see how quick society can respond to the COVID pandemic when your child struggles with opioid use disorder, and we see this very slow progress with respect to the opioid poisoning epidemic. And I believe that's because of the difference between a disease which people feel can affect them versus something that happens to those people over there because of otherizing. So in April, a member of the Toronto Police Service's drug squad died at home of a fentanyl overdose. And I'm asking you, how easy would it have been for him to use a safe consumption site or to ask for help? Criminalization of drug use is a huge barrier to treatment. Decriminalization would eliminate this barrier and also address one form of systemic racism and social unrest in the disproportionate number of persons of color incarcerated for drug offenses. In 2015, 1 in 9 deaths among youth aged 15 to 24 in Ontario were opioid related. Tara Gomes of the Ontario Drug Policy Research Network recently recrunched the numbers and advised that now in 2018, 1 in 6 deaths among youth aged 15 to 24 opioid related. Let that sink in. We're allowing youth dependent on illegal drugs to play Russian roulette with their lives. We have a duty to protect them, both those seeking treatment and those who are not. Waitlist at Pine River Institute, the only long-term residential treatment facility for youth in Ontario, is 14 months, and there are over 200 youth on the waitlist. We need strategies to minimize the risk that youth overdose or are criminalized while they wait for treatment. And the same is true for those not seeking treatment. Safer supply and decriminalization should be key parts of that strategy, particularly during COVID-19, when social distancing is required and it's so difficult to respond to an overdose. Addiction is the severe end of SUD, is self-harm. It's compulsive drug use in spite of adverse consequences. The primary purpose of criminal law is to protect people from other people, not to protect them from themselves. Protecting people from themselves is properly done through our health laws. As we have recognized with alcohol and cannabis, there's nothing inherently criminal in consuming a substance or in self. Let me give you an analogy. Prior to 1972, it was illegal in Canada to attempt suicide. We look at that law today and think it's ridiculous. How could we ever help someone struggling with a mental health condition by incarcerating them or punishing them? And it's time we realize the same thing for drug substance use disorder. I'm asking you to consider if the criminalization of drug use is responsible for the very different societal reactions to attempted suicide on the one hand and addiction to illegal substance on the other. So I'm asking you to step into my shoes and imagine your child, so imagine your child is suicidal and on a bridge. It's recognized as self-harm and an illness. We intervene, we side with the family and the child against the illness. We provide treatment, although there are huge wait lists here. And we don't talk about their poor choices that brought them to the bridge or say they have to hit rock bottom or they have to want help. And we don't talk about the right to jump. And there's no societal talk of thinning the herd. But if, like the families I represent, your child is addicted to an illegal substance, so they're self-poisoning or playing Russian roulette, it's not recognized as self-harm or an illness, but as a criminal activity. We don't intervene regardless of age, which is the same thing as siding with the illness against the family and the child. We provide punishment in a criminal record instead of treatment. We talk about choices. They have to rock bottom. They have to want help. We talk about the right to refuse treatment, which is the right to jump, and there's societal talk of thinning them.
Jeanette, you're just over 5 minutes. Can I ask you to wrap up in a sentence, please?
Yep. Criminalization prevents our family members from getting the help they need. With political will, decriminalization, safer supply are the fastest and least expensive interventions to save lives. It's the least we can do. And some will be afraid to do this. Our families are much more afraid of the status.
Thank you very much. Are there any members of the board who have questions? Okay, seeing none, we're going to bring this into committee. Now for the board, it's 12:25. We are in committee on this item, and we have one final item, which is the new business item. My suggestion would be that we move to extend to finish. I suspect that we will be finished in 30 to 45 minutes. If we were to break for an hour and return, I think we risk quorum. So can we just go back to the screen so I can see everybody? Is there anybody if people comfortable? Let me see a shake of the heads if people are not comfortable with proceeding to finish. I suspect we'll be done in 30 to 40 minutes. Okay, seeing none, I will move a motion, because we're coming up on 12:30, that the Board of Health extend its meeting past the 12:30 lunch recess to complete the agenda. I believe that motion is just being put on the screen. All right, we have a technical glitch here. There it is. All right, we're good. So that has been moved. By way of a show of hands, all those in favor? Opposed, if any? That is carried. So we will move to extend to finish. So this is now in committee. Questions of staff. We have Susan Shepherd here who gave the presentation. Do I see any questions of staff? Okay, seeing none, we're going to move into speakers. Could you put your hand up and indicate if you'd like to speak on this item? Councillor Perks. Would anybody else like to indicate if they wish to speak? Okay, Councillor Perks, yourself, and then I have a few remarks as well. When you're ready, Councillor Perks.
Thank you. Members of the board, I urge you to support the recommendations. And several times discussed the opioid crisis. Need to know that during the pandemic, if anything, it's gotten considerably worse. And the Drug Strategy Secretariat has provided us with some very good guidance here about how we can move forward and try to save lives. I wanted also to let you know that at the drug strategy table includes people from a number of city departments, the Toronto Police Service, representatives of people who use drugs, community agencies who support people who use drugs. We've had a robust conversation about many of the items in front of you today, and we've endorsed them and put them in front of you and asked for your support. I also think that there's a moment here where we can think about the conversation around decriminalization. The panel did endorse the recommendation in front of you. I want to note, though, that two of our members who are members of the criminal justice system feel it's inappropriate. One, a Toronto Police Service representative, and another, someone who is a judge in drug treatment court, felt it was inappropriate for them, who are part of the enforcement of the law, to take a position. I just wanted to provide that footnote. But the thing that I think is interesting is that this is an instance of an area of social policy where we are moving to say this is not something that should be handled by the criminal justice system, but rather by the health system. By doing that, we are trying to find tools that actually provide better outcomes for people and giving someone else to call when you call 911. And I think those are important things for us as a society thinking about right now. And really encourage you to apply this thinking broadly in the months and weeks in front of us, and to support the recommendations here.
Thank you, Councillor Perks. Let me just see, last call. Anybody else wish to speak on this item? Okay, I have a few remarks. I'll put my time on. First, I have an amendment that have worked very closely with Director Mulligan on, which is to request the Medical Officer of Health, in consultation with the city's Emergency Operations Centre, to work to provide the necessary PPE to the overdose prevention sites and community health centers that operate harm reduction facilities in the city and currently are not receiving adequate PPE from the province. And so that is an amendment being moved. And thank you, Director Mulligan, for her work on this. Can I just start by thanking staff, Susan Shepherd, who gave the presentation and has led within Toronto Public Health this file for so many years so remarkably well. The Toronto Drug Strategy Implementation Panel for their leadership and hard work, and in particular, Chair Perks for his relentless determination on this issue, and in particular, all the frontline workers and indeed people who use drugs. They need to know, and they should know, that when it comes to the city's Board of Health, their work and their lives are deeply important to us and matter deeply. For 6 years, my 6 years on this board, there's perhaps nothing we've been more focused on and that I've been more focused on than the overdose crisis. And while, and the report speaks to it, there has been tremendous progress made both in the city and in partnership with some of the other levels of government, whether it's on distribution of naloxone or the implementation and opening of supervised consumption sites to the drug checking project that we've rolled out. It's also true to say that this progress, notwithstanding how significant it is, has been painfully, deadly, and far too often slow. And COVID has accelerated and magnified the consequences of the current criminal justice approach to drug use. As our staff have noted, April was the worst month in 2.5 years for recorded fatal overdoses in our city. And that happened because just as COVID-19 has drawn attention to and exposed and created challenges for people who are homeless and people who live in long-term care homes, so too has COVID wreaked havoc for people who use drugs in our streets. The combination of a lack of harm or a reduced number of harm reduction services and a tainted and illicit drug supply being on the street has made it very, very acute and problematic. And so the next big move, what's in front of us here, and I believe the next big move, not just for this city, but for this country, is a safe and regulated and legal supply. That's what we're talking about. It may sound controversial to some, but it is sensible. It is evidence-based. It is healthcare, and it is compassionate. It's the right approach. Toronto Public Health has been working closely with a number of community partners who have submitted applications to the federal government for safe supply, and we too have submitted an application to the federal government, and I'm hopeful that those applications will be approved soon. I'm hopeful of that. I'm less hopeful that the province will step up to help support it. But this has been a long 6 years, no more so than for people who use drugs and people who work with people who use drugs. And while there may have been some big wins in harm reduction, to truly end the overdose crisis, we need to have the big conversation and we need to see the big move on safe supply. And I think Toronto is ready for it, and I hope we'll have positive news to share on it soon. Thank you very much. I will ask, I have an amendment. Is there, if we could have the screen so I can see everybody, is there a desire to take the staff recommendations and the amendment as a package? If you could raise your hand and indicate if you would like a recorded vote on the first. Okay, not seeing that. So
Me.
you would like a recorded vote on the first amendment? Or on the...
Would it be possible to break down the first recommendation, vote separately on 1, 2, 3, and 4?
Okay, so let me do it this way so it's very clear. We're going to start by I will move my amendment, which was for if the amendment can be put on the screen, this is for the city, the MOH in consultation with the EOC to provide PPE. Is there a desire, Trustee LaPretti, for a recorded vote on this specific amendment? Okay, so on this amendment, I will ask for a show of hands. This is just the amendment. I'll come back to your request, Trustee LaPretti. All those in favor? Opposed, if any? Okay, that carries. So on the staff recommendations, Trustee LaPretti, could you just confirm, do you want to separate out some of the recommendations for a separate recorded vote? Is that correct?
If that's possible.
That is possible. So there are 4 recommendations. Do you want to have a recorded vote on all 4 of them, or is there a specific one you want to have a separate vote on?
Number 1.
Number 1. Okay, so what we'll do is
First recommendation.
Okay, so we're going to have a recorded vote on number 1, and then we will have a recorded vote on the balance of the item being 2, 3, 4, 5, and 6. Did I accurately capture what you're looking for, Trustee LaPretti? Yeah. Okay, so I will then turn it over to the board secretary. Could I ask we're going to have a recorded vote on the first recommendation. This is specifically related to decriminalization. And then we will have a subsequent recorded vote on the bulk of the rest of the recommendations 2 through 6. So I'll turn it over to the recording secretary.
Directors, when I call your name, please unmute your mic, indicate your vote by stating in favor or opposed, and put your mic back on mute. Ashna Bowery. Ashna Bowery. Stephanie Donaldson.
Favor.
Angela Johnson. Angela Johnson. Councillor Cynthia Lai.
Favor.
Councillor Mike Layton.
In favor.
Councillor Kristen Wong-Tam. Councillor Kristen Wong-Tam. Councillor Joe Cressy.
In favor.
Trustee Ida LaPretti.
Opposed.
Councillor Jennifer McKelvey.
Favor.
Kate Mulligan.
Favor.
Councillor Gord Perks.
Favor?
Peter Wong.
In favor.
Sue Wong.
In favor.
And Mr. Chair, that carries.
Thank you. And then let me just confirm in the interest of time, Trustee LaPretti, do you want a recorded vote on the balance of the item or just a show of hands? Just a show of hands. Okay, thank you. So on the balance of the item, which is staff recommendations 2 through 6, all those in favor, please raise your hands. Opposed, if any? Okay, seeing none, that carries. Can I just confirm, do I need a motion as amended with... Okay, and then so I'm told I do. So motion as amended, Councillor Perks is, are we sure I need a motion as amended? Okay, I'm told I do. So motion as amended, all those in favor? Opposed? I saw that, Trustee Lorpetti, thank you. That carried, perfect. Okay, we will now, so that is item HL 17.2. We now move on to our final item, which is the new business item that was posted and circulated, which is, I have put on the agenda addressing anti-Black racism as a public health crisis in the City of Toronto. Let me see if there are any questions of staff. It is a new business item for them, but are there any questions of staff? Okay, seeing none, we're going to bring it in for remarks. Speakers on this item, if you could raise your hand to indicate if you would like to speak. Director Mulligan, I see. Anybody else? Councillor Perks, I see. And I will put myself on the list. Okay, I will turn it over. It's going to be Director Mulligan followed by Councillor Perks. Over to you, Director Mulligan.
Mr. Chair, I have been asked by mentor, Mr. Levin Gieber-Mikhail, who's the Executive Director of Taibu Community Health Center, to read some remarks on his behalf. And he says, I've been reflecting on the meeting tomorrow, and in view of the fact there are no Black members on the board, I thought maybe you could read out this message. First of all, it's important to acknowledge the efforts and strategic decisions that the Board of Health has taken in recent times to address health inequities and injustices in our great city, but more so as it relates to Black Torontonians. I personally would like to acknowledge the resolution passed in the fall and the leadership shown by the Board of Health to acknowledge that community violence should be considered as a public health issue that requires a public health approach. It was a privilege to have deputized at that particular meeting. As the leader of the organization and on behalf of the Board of Directors, staff, and volunteers of Taibu Community, we're also very cognizant of the resolution that you passed in December to participate in the anti-Black racism capacity building session under Taibu's Black Governance and Leadership Project. We appreciate your commitment. We are looking forward to participating in a difficult, uncomfortable, but vital discussion once the COVID-19 restriction is lifted. In particular,
it seems we've had a technical difficulty on Director Mulligan's end, so I have paused her time. And what I will do is when she rejoins, we will go back to Director Mulligan at the 1 minute 40 second mark. And I'll ask if our team here in the clerks could reach out to Director Mulligan directly just to try to bring her back in. Power fluctuation, she's telling me. So I'll ask the clerks to reach out to her directly, and I've put her time on hold. And I will now turn to our next speaker, Councillor Perks.
Thank you. Regis Korchinski-Paquette lived in Ward 4 and died during an interaction with the Toronto Police Service. She died after her family had called for assistance with a health emergency. The call for Toronto to review how we deal with health emergencies, other safety and security services is timely, is necessary, and is just. Today at the Board of Health, we take one small piece of this work and confirm that we consider Black racism to be a public health issue. An important step, a first step, and I want to commend Chair Joe Cressy for the work he's done to bring this piece in front of us today. A lot to do. I urge you to support what the Chair has put in front of us today. Give you my undertaking to continue to work on these issues with you days and weeks move on.
Thank you, Councillor Perks. While we're still working to bring Director Mulligan back, are there any other speakers on this item? Okay, I will put myself on the list and I will speak. So let me start by stating what I know many have seen is that we've witnessed a difficult few weeks. And the pain, the hurt, the racism felt by so many Black Canadians and people by color it's difficult to hear. These are experiences that I, as a straight white man of privilege, have never experienced. And so while this has been difficult, far too difficult for those on the front lines and for those with lived experience, it is my hope that it is also an awakening. We see movements come and go. My hope is that this is an awakening that will provoke not only changes to behavior, but changes to the policies that contribute to systemic racism. Anti-Black racism is a public health crisis. Black Torontonians are twice as likely to live in poverty than non-visible minorities. That's a crisis. Black children, 44% of Black children live in poverty, compared to 15% of non-racialized children. That's a public health crisis. Black women earn 57 cents for every dollar that non-racialized men earn. That's a public health crisis. I think as the Board of Health, we have long been clear that tackling racism requires system change and behavior change. It requires tackling the social determinants of health. You cannot tackle systemic racism if you do not tackle housing inequities, employment status, and criminal and police reform, criminal justice and police reform. It requires data to measure the disproportionate impact of poverty and race on health, and it requires budgets that focus on upstream health outcomes and promotions. We know, and we've long known, as the Toronto Board of Health, where we roll rocks up hills on this board, that society and governments of all types spend far too much money on emergency rooms and emergency services, and not enough time or money tackling the roots of inequality and racism. And so today, it is an important declaration for us to make that anti-Black racism is a public health crisis. It is an important affirmation for us to commit that we will continue to tackle the social determinants of health. It is critically important that as we look to the 2021 budget process, that our medical officer of health reports to this board, to us, on how we can best reprioritize city funding and city services to tackle anti-Black racism and health inequity. It's critically important that we reschedule the planned anti-Black racism training for us. And included in this motion, and it was alluded to in the remarks that Director Mulligan was just saying, that when the city's Civic Appointments Committee makes recommendations for representation across the city on agencies, boards, and corporations, that they do so in a manner that reflects the diversity of this city and that helps us to tackle the inequities of this city. And that cannot be done if we don't have representation at tables like this. And so I thank the members of this board for allowing me to put this item on, for allowing us to bring this item on the agenda. We know that this is not and cannot be a discussion in the wake of protest, but rather a prolonged agenda item so that we can tackle systemic inequality and racism once and for all. Thank you very much. With that, I'm going to turn it back to Director, who we lost momentarily there. And sorry about that. So Director Mulligan, when you're ready, you can restart. You had used about 1.5 minutes on your time, but when you're ready, restart. Welcome back.
Mr. Chair, and thank you for your remarks and for bringing this motion forward on behalf of many of us on this board and the conversations with many people in the community. So I'll just continue reading the remarks. These are not my remarks. These are the remarks from Lieben Gieber-Mikhail, who is the Executive Director of Highview Community Health Center, which has a focus on Black health. During this particularly difficult time, it's clear and apparent that when we're witnessing the pain and suffering of a population and its fight against anti-Black racism, I would like to reaffirm the benefits of such a relationship and engagement with the subject matter and stakeholders. But at the same time, I also hope and would like to point out that you, as members of one of the critical governance and leadership spaces, how much more important it is to have the voice of the suppressed, oppressed, and marginalized communities in the city. Black voice. Board of Health and Toronto Public Health have shown leadership in addressing anti-Black racism. You responded swiftly to the call for race-based data collection during the COVID-19 crisis to be able to understand the disproportionate impact of the pandemic on Black and other racialized communities. However, my message today is to ask you to continue to engage with anti-Black racism. This is a systemic, deep-seated, and long-established injustice and will not go away and dissipate because of, as important as they are, a few resolutions and actions. COVID-19 is demonstrating that it will stay with us for a while, and its impact will require considerable investment and a long-term plan. It is even more significant with anti-Black racism and its effects. I ask you to work with key stakeholders, including Black health leaders, in developing a long-term and a strategic plan, a 10-year strategy and a plan to address anti-Black racism in our public health. We are witnessing through media the death of members of the Black communities is not even the tip of the iceberg. People are dying due to disproportionate chronic conditions like diabetes, hypertension, heart disease, mental illness, and the list of examples is too long to name them all. The challenge is further rendered complex because of the interplay of the other social determinants of health, poverty, unemployment, and living conditions. Black communities are ready to engage and to bring about change. We have been ready for a very long time. We have been calling for change in different ways, including protests. We just need the system to show willingness to engage. We are waiting for the systems and institutions to respond to the cries and screams of the community. We have no choice but for change to take place. Can't breathe. We are dying. We are Torontonians. We are a proud and resilient population. We deserve better. We deserve much better. It can be better.
Thank you very much, Director Mulligan, for reading those words. Are there any other speakers on this item? Seeing none, and this is our final item of the day before we adjourn, I would ask for a recorded vote on the new business item. And so I'll turn it over to the recording secretary for a recorded vote.
Directors, when I call your name, please unmute your mic, indicate your vote by stating in favor or opposed, and put your mic back on mute. Ashna Bowery. Ashna Bowery. Trustee Stephanie Donaldson.
In favor.
Angela Johnson. Angela Johnson. Councillor Cynthia Lai.
Favor.
Councillor Mike Layton.
In favor.
Councillor Kristen Wong-Tam. Councillor Kristen Wong-Tam. Councillor Joe Cressy.
In favor.
Trustee Ida Lepretti.
Favor.
Councillor Jennifer McKelvey.
Favor.
Kate Mulligan.
Favor.
Councillor Gord Perks.
In favor.
Peter Wong.
In favor.
Sue Wong.
In favor.
Mr. Chair, that carries.
Thank you to the members of the board for that unanimous display and support. That concludes our agenda for today. So thank you very much, members of the board. We will be in touch daily, as we often are. And our deep thanks to both TPH staff, as well as staff from the clerk's office here at the city who have made this happen remotely. So there is a clap for all of you and clerks. Thank you kindly. So farewell. Thank you, everybody. We'll talk soon.